Yeah, we are live now, ma. So, good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Amogs Emergency Obstetrics Committee webinar. So, it's my privilege to introduce the moderator of today's webinar, Dr. Monica ma'am. Ma'am is the consultant obstetrician and gynecologist at Mangalya Nursing Home and Atharva Fertility Center, and also
Saiti, that
PAC
should be
Committee
fine.
chairperson, Amogs.
Yeah,
I
that should be
welcome you,
fine.
ma'am.
Thank
I hand over the session to you.
Yeah. Thank you so much, Saiti, for the kind introduction. We are here to begin with the Amogs Emergency Obstetric Committee with Akola and Yavatmal societies. Thank you, Dipali madam and Dr. Charita ma'am for agreeing to be a part of this webinar. We will first evoke the blessings of Lord Saraswati with an inauguration, and then we will proceed with the webinar. Thank you, Saiti. It is my proud privilege to introduce Dr. Sneha Bhuyar Madam as the chairperson of the Emergency Obstetric Committee. This webinar is a brainchild of Madam. Madam has been striving very hard to get focused programs to the rural interiors of Maharashtra so that people can learn emergency obstetrics and to handle the cases better. Madam has many firsts to her credit. She is the first national faculty from Yavatmal, the first fellow of ICOG, the first Foxy chairperson from Yavatmal, the first person to receive National Individual Awards by Foxy as Unsung Hero SN Malhotra and Durusha Community Service Awards, the first one to receive the State Award of Healthcare by Government of Maharashtra. She's the first one to have the first 30 plus national publications and more than 300 talks. Ma'am, we welcome you for a welcome address, and would invite you to introduce our chief guest, Kiran sir, and our guest of honor, Dr. Amay Purandre, and our special guest, Dr. Rajesh Modi sir.
Yes. Thank you. Thank you so much, Monica. A very good evening to all of you. A very good evening, especially to all the respected seniors of Amogs, especially President Amogs, Dr. Kiran Kurtakurti, Secretary Dr. Bipin Pandit, Vice Presidents, Dr. Amey Purandare, the Senior Vice President, will be the President soon of Amogs, and of course, Dr. Bharti Abhankar, who is the Vice President of Amogs. We have a special guest, Dr. Rajesh Modi, who is the past Vice President of Foxy, and Dr. Rajendra Singh Pardesi, the immediate past President of Amogs. I welcome all of you. Special thanks and welcome to both the President and Secretaries of Akola and Yavatmal Societies, my own people, my dear friends, Dr. Dipali Shukla, the President of Akola, and Dr. Shalaka Adgaonkar, Secretary of Akola. Dr. Charuta was busy, should be joining soon, President of Yavatmal Society, and Dr. Sushma Tarak, Associate Professor and Secretary of the Yavatmal Society. Of course, Monica, a very dear friend who always manages the show very well. I welcome all of you. And Monica has already talked about the very intention of this webinar and the virtual programs to reach the interior of Maharashtra, where, we obstetricians are facing these problems in day-to-day practice. And all of you should be well versed, not only the theoretical aspects, but case discussion and, of course, the practical tips what we can deliver to you. So it's my pride and privilege to introduce our own President of Amogs, Dr. Kiran Kurtakurti, who is a very dear friend since long, I think more than 25 years. The committee chairperson of MTP committee in the past 2009 to 11 as MTP committee chairperson. Yes, everybody knows him so well. Yes, yes.
Yeah. Thank you.
Yes,
thank you so much.
I'm handing over to you. Yes.
Yeah. Thank you so much for that kind introduction. And really, it's a pleasure on always to be on the Amogs dais and welcome all my Amogsians as well as those who are not members of Amogs. But I am sure that with the with the charisma and charm of Sneha, I think this program will not only be watched by Amoxians, but also will be watched by Foxians also. So a warm welcome on behalf of Amox to everyone. Today's coordinator, Dr. Monica. Monica is doing a fantastic job as usual, and as Sneha rightly said. And Sneha, a very special thanks to you, because for the past 3 years, I have seen you working closely for Amox, and the amount of work that you are doing. I remember that when my year started, the only committee that you requested was the emergency obstetric committee. So and that's the passion which with which you are working for that committee, and even today you are working it with the same zeal and enthusiasm which you took over about a year back. So I really appreciate whatever you are doing, and I wish that you continue to do the same for Amox as well as for our national body also. My close friend, brother in Amox, Ameya, and of course Rajesh, very, very, very old friend. I mean, hi Rajesh. It's really a great thing to see you, pioneer of the daycare hysterectomy. Rajesh, your name is probably on the mouth of each and every Amoxians, not only Amoxians, I'm sure, but the entire Foxy fraternity also. Dr. Deepali Shukla, Deepali ji is after me. Ki kab aoge Akola? So I'm yet to respond to that, but I shall we will do so in the short time. And well, what can I say about today's speakers? Dr. Geeta, we all know, has been the editor of the Jogi, and I'm sure that Geeta is all set to play a larger role, not only in her local society but also at a national level. So I have my good wishes to Dr. Geeta, and of course the other speakers also, Dr. Shashiwala Kabra, and of course then we have the moderation which will be done by Sneha. So without much ado, Sneha, best wishes to you, best wishes to the program, and let us all come together for the good of of our fraternity. And I take this opportunity to welcome all of you for the Amox Chandrapur conference. Chandrapur Society is doing a very good thing, and they are putting a lot of efforts. So I hope, wish and pray that I see you all not only at Chandrapur also, but at AICOG, and at AICOG also Amey is here. And Amox would like to thank Dr. Rishikesh Pai, Dr. Nandita Pashetkar, and Dr. Niranjan Chauhan and the entire team of AICOG for giving one full session for Amox. I had a call from Rishikesh a couple of days back that a 1 hour session is going to be allotted to Amox, and really appreciate the gesture of AICOG committee members, and of course Rishi, Nandita, and Niranjan, and others from the AICOG. So without much ado, I would request Dr. Sneha and Monica to get on with the program. Thank you so much.
Thank you so much, Dr. Kiran, for being so proactive and supportive always. Once again, I welcome Dr. Charuta Ranade, who has just joined, the president of IOGS, and also I welcome both the speakers, dear friend Geeta and Dr. Shashilata Kabra Maheshwari from Delhi. So the topics are very, very important, and without much ado, I would like to go ahead with the introduction of the guest of honor, Dr. Ameya Purandare, the very illustrious personality with highly decorated CV. That's the only thing I can say. Mayor, I'm sure you may have pages and pages for your CV, but we are very happy to have you, and of course, eager to listen to your precious words. Over to you, Dr. Mayor.
Thank you, Dr. Sneha, for those kind words. My sincere congratulations to you and to Monica for all the passionate work that you have been putting forward for this very important committee of Amogs, that is the Emergency Obstetric Committee. We also must appreciate the fact that you have chosen such eminent speakers for today's program. And it is not just the theoretical aspect that you have chosen, but also the practical case scenarios, which will be after the two talks by eminent speakers like Dr. Geeta Balsarkar, our past editor-in-chief of the Journal of OBGYN, a very, very well-known academic figure all over India, and sincere wishes to her for her endeavor in the Foxy upcoming election. We all are with you and wish you all the best. Also Dr. Shashi, with whom I have worked closely both in the Emergency Obstetric Committee and also the Practical Obstetric Committee with Mitra Saxena. And we did a workshop on internal iliac artery ligation. And really, Dr. Shashi is a very good teacher and a very good clinician. So we are privileged to have her. My congratulations, heartiest congratulations to Dr. Kiran Kurtakoti for an excellent tenure. I'm a little tense if I can live up to the high standards that he has set. And a special mention to Dr. Rajesh Modi. Dr. Rajesh Modi and me are batchmates in the same clinical batch. We did our gynac posting in the undergraduate days together, Rajesh and me from GS Medical College. But what I really appreciate for Rajesh, and I always often tell him that he is the Raj Kapoor of Foxy, because he took endoscopy to the movie theaters with his 3D programs, and he made us see what we could not really appreciate sitting on those small monitors to such large screens. So Rajesh, you made the more than large life of endoscopy. Of course, you are the pioneer of daycare endoscopy as well, like Kiran mentioned. And I think it is a unique concept which really is not only cost effective, but convenient to the patients as well. Special mention to Dr. Dipali and to Dr. Charuta. I think Akola and Yamatmal societies are the real superstars of Amogs at Foxy. If you take the history of these two societies, the number of prizes they have won is really worth mentioning and acknowledging. So congratulations for the hard work that you all carry out and for participating very earnestly in Amogs activities. Last but not the least, I'm very thankful for all Amoxians who have joined in today for listening to this program. I'm sure they will benefit from the very important topics and cases that we are going to be discussing as a part of this program. Congratulations once again and wish you all the best.
Thank you so much, Dr. Ame, for your very elaborate discussion and, comprehensive discussion about the program, I would say. Thank you so much. I think that Dr. Bharti is going to join a little late, so we will have her words later. So may I invite, do we have her? No. So, we invite Dr. Rajesh Modi, who is, lots have been already said about you, Rajesh. So, without much ado, I think we would like to listen to you better. So, over to you for your precious words.
Thank you very much, Dr. Sneha. It's really wonderful to join your program today. You have always been a good friend and a well-wisher. Similarly to Dr. Kiran and Ame, very close friends for a number of years. And this is an amazing thing which is being done through Amogs. Plus a lot of activities which I keep seeing on the WhatsApp group which Kiran has introduced under the banner of Amogs. I really hope that it reaches each and every practicing obstetrician throughout Maharashtra. It's so much more easier to reach everyone through the mobile and the Zoom compared to what I can do in PVR, as Amey mentioned, because this becomes accessible to every single person. And that actually is what is required for proper dissemination of whatever practical knowledge and skills you want to impart. And thank you again for this privilege to be on this platform along with you. It's really a pleasure for me, Dipali and the Yavatmal Gynec Society. Nice that we are working together and having the programs to be propagated for all our members. Thank you, Dr. Sneha, again.
Thank you so much. Thank you, Dr. Rajesh. And I now, with Dr. Monica to, go ahead with the academic session. Thank you so much, all of you, once again.
Thank you, Kiran sir and Bipin sir, for allowing us to conduct this webinar under the aegis of Amogs. Thank you, Amay sir and Rajesh sir, for your gracious presence today. We are indebted to you. We now move forward with the academic session. Our first speaker for today, Dr. Geeta Balsarkar, Madam. Let me take the privilege in introducing our chairpersons, Dr. Dipali Shukla, Madam, and Dr. Sushma Tharak. Dr. Dipali Shukla, Madam, is the current president of Akola OBGYN Society. She is the director of Shukla Test Tube Baby Center, a member of IFS and ISAR. She has been a faculty in state and national conferences and the organizing secretary of Akola Hysteroscopy Workshop. We welcome you, ma'am.
Hello.
Dr. Sushma Tharak, Madam, is currently the secretary of Yavatmal OBGYN Society. We welcome both of you to chair this session. I request Dipali, Madam, to please introduce our speaker, Dr. Geeta, ma'am.
Yeah, good evening, everyone. My heartfelt thanks to Amogs Emergency Committee, Obstetric Committee, especially Dr. Sneha, Madam, and my dear friend, Dr. Monica. I congratulate Amogs Emergency Committee for arranging a webinar on such important topic. PPH, which is nightmare for every obstetrician, occur in 2 to 10% of deliveries. It may be due to atonic PPH, traumatic, retained placenta, or coagulopathy. It is seen that 60% cases of PPH occur in low-risk patients. Along with oxytocics, fluid and blood management forms a pivotal role in PPH. Many times we rapidly transfuse the patient and that may lead to complication. Today we have eminent speaker Dr. Geeta Balsarkar, Madam, who will going to highlight us on fluid and blood management in PPH. I'm happy to introduce Dr. Geeta, Madam. She is Editor Emeritus of Journal of Obstetrics and Gynecology of India. She is Secretary of Mumbai OBGYN Society 2024. She is President Association of Medical Women in India, Mumbai branch in 2021. She is President Mumbai Menopause Society in 2021. She is Chairperson of Young Talent Committee FOXY from 2014 to 16. She is recipient of prestigious Hargobind Foundation for Study of Fetal Medicine in 2008. And she is professor at St. GS Medical College and Nauroji Wadia Maternity Hospital. And she have undergone training for PPIUCD program and is also faculty member of many training programs, as well as to read my...
Thank you, madam.
Yeah. Welcome. We
Thank
welcome
you, madam, for that
and
kind
we are
introduction.
to listen to you.
Yeah. Can I share my slides, please?
Yes, I think you can. Yeah.
Yeah. Can you see?
Yeah, just make it full screen. We can see this.
Yeah, full screen. Actually, I would like to thank Dr. Kiran Kurtakoti, Dr. Rajesh Modi, and Dr. Sneha Buyar, Dr. Ame Purandre for having me here to speak in front of you. Actually, today is a very black day for the doctors. If you all know what has happened in Tamil Nadu, in Chennai, a medical oncologist was stabbed 7 times by a patient's son. And here in Mumbai, in Rajawadi Hospital, as well as VN Desai Hospital, 2 doctors, senior doctors, gynecologists have been badly beaten up by the relatives of a woman who died on the 7th post-operative day. And after the neonatal death, they ransacked the NICU in VN Desai Hospital as well. So the entire country is on an alert. And we as obstetricians, we have to train ourselves well, not only in the clinical aspect, but also in counseling and how to talk to the patients and how to counsel the relatives as well. And as Amogs, FOXY, and all the national and international bodies, we have to put forward to the government and the authorities to give us good protection so that we can continue our duties without any fear. My son, who is a gynec resident at VN Desai Hospital, is so petrified. All the residents were locked up in a room because the relatives have ransacked the hospital. And finally, he has come home at 4 o'clock. So I can speak to you with little peace of mind. So my topic today here is blood and fluid management is PPH. So why are we talking about this fluid management? Because it is very crucial for appropriate response to the postpartum hemorrhage. We cannot tackle postpartum hemorrhage if we don't know much about the fluid management. What is the first manifestation of blood loss? That is tachycardia and hypotension. But these may not be readily apparent in healthy postpartum women unless the blood loss approaches 25% of the total blood loss. That is about 1.5 liters in a term pregnant female. So we should not wait for the tachycardia and the hypotension to occur before we start the patient on fluids accurately. In addition to whatever fluid, whatever blood you may give, you have to diagnose the source of bleeding as a treatment strategy side by side. If you don't diagnose your source of bleeding, only giving blood and blood products and fluids is not going to save the patient. We have to closely inspect the placenta to ensure if it is intact and it has come and it has been completely extracted, and appropriate visualization of the cervix and birth canal to rule out any laceration. This is very, very integral for the management. Once the source of bleeding is identified, then we should swiftly address the etiology, and along with that continue with your fluid management and blood products. It is the mainstay of management. The leading cause of postpartum hemorrhage, as our chairperson has already discussed, it is uterine atony, which accounts for 80% of the incidence of postpartum hemorrhage. It can completely take you by surprise. It can happen in a completely low risk patient. And the mainstay of the therapy is uterotonics, active management of third stage of labor, and the uterine compression, as well as the drugs. If acute hemorrhage persists, the most important next clinical step is appropriate and rapid response to hemorrhage. Initiate the postpartum hemorrhage bundles, which calls for the unit standard obstetric hemorrhage protocols and hospital-wide massive transfusion protocols, for which we have to do rapid assessment of the blood loss. I'm not here going to discuss about how to assess the blood loss. That will be an entirely different chapter by itself. Now, before we transfuse any patient, we have to know this, how to assess the blood loss and resuscitate. The rule of 30. If heart rate increases by 30, if systolic BP reduces by 30 and respiratory rate is more than 30, HB or hematocrit is less than decreased by 30%, or urine output is less than 30 ml per hour, that means 30% of patient's blood volume or 1/3 of our blood volume is already lost, and the patient is in moderate shock. The shock index can also be calculated, that is heart rate divided by systolic BP. Normal is 0.5 to 0.7 and significant hemorrhage is 0.9 to 1.1. In obstetric shock index, the normal is 0.7 to 0.8. More than one massive hemorrhage it requires, resulting in almost replacing 80% of the blood. So one of the first way to resuscitate. So what is the aim in starting IV fluids and the blood and blood product is restoration of blood volume, and second is the restoration of the oxygen carrying capacity. So the therapeutic goals of management of a massive hemorrhage is to have anytime is to have hemoglobin more than 8 grams, platelet count more than 75,000, prothrombin time less than 1.5, and fibrinogen more than 1. When this thing has reached, then we should not over infuse or over treat the patient, and we should stop our fluid and the blood management. So coming to the resuscitation fluid, in deciding which fluid preparations to use during resuscitation, there are two main types of intravenous fluids to choose from, either crystalloids or colloids. We all know that crystalloids are normal saline, ringer lactate, or 5% dextrose, and colloids are human albumin, gelatin solution like Hemaxil, Dextran, and Heta starch is also available nowadays. So basically, we have to differentiate between whether we want to use crystalloids or we want to use colloids. So the main important thing is crystalloid is sodium chloride, ringer lactate, hypertonic saline, Hartmann solution, whereas all the albumin solution, the hydroxyethyl starch, gelatins, these are colloids. The main thing is the colloids are retained in the interstitial space for a longer time and are not lost. Therefore, in such certain conditions, you may decide decide to start the colloid before giving crystalloid. But the primary resuscitation fluids are the crystalloids. The colloid solution, they're more effective in expanding the intravascular volume. And normally we take 1:3 ratio of colloids to crystalloids. That means after giving 3 crystalloids, you can decide whether you want to give 1 colloid to maintain the intravascular volume. Semi-synthetic colloids have a shorter duration of effect than the human albumin solutions. But while we are giving fluid resuscitation, we can reverse the vasoconstriction. But remember, it will also dislodge the clots, cause hypothermia. It can cause other side effects of it like hemodilution, all of which can lead to coagulopathy, reduced oxygen delivery, increase in acidosis of the patient, eventually leading to more bleeding. Therefore, we feel patient is not bleeding, but after starting IV fluids for some time, the patient has started bleeding again. Then we have to remember that fluid infusion by itself can also increase the bleeding by reversing vasoconstriction, dislodging the clots, causing hypothermia, causing hemodilution, thereby causing coagulopathy and reduced oxygen delivery and increased lactic acidosis. So all of these can increase your bleeding, and therefore it is very important side by side to identify the main cause of bleeding and treat it. Fluid resuscitation is begun immediately with administration of Ringer lactate solution. Ringers is an isotonic crystalloid solution with lactate added to correct the possible metabolic acidosis in the patient. Initial volume of 3 liters is administered, which will approximately replace 75 ml of the blood volume. So when you start resuscitating, especially in postpartum hemorrhage, you should initially give about 3 liters of the Ringer lactate solution. Now, if you see this particular chart, it is the types and composition of the resuscitation fluid. If you see, normally what we use is Boluin or Hemaxil. They have the normal saline and the Ringer lactate solution to the amount of sodium, potassium, calcium, magnesium, chloride, and acetate that is present in it. However, each patient is individualized and is different, and depending on what the patient requires, we may have to start the colloids or the crystalloids or whatever is available in our operation theater at that time. Now, this is roughly a chart which says, because all our pregnant patients, especially our high-risk pregnant patients, have edema. So if there is more edema, then giving crystalloids may just cause more fluid to be lost in the third space. Therefore, this chart shows us that if there is more edema or less edema, then how do we start crystalloids or colloids in the ratio of 2 or 3:1. And if there is less edema, then we may have to go into 1.5:1. Now, this shows that in hemorrhagic shock without apparently severe bleeding, if there is no apparent severe bleeding and you're suspecting hemorrhagic shock, the first thing is the erythrocyte concentrates or the packed cell volume that we give, plasma and thrombocytes are preserved. An alternative is an albumin or balanced crystalloids, but without apparent bleeding, we can give balanced crystalloids and then think about erythrocyte concentration or packed cell volume or in plasma or albumin. So if there is bleeding going on, you can see the bleeding, then you immediately give PCV, plasma and thrombocytes. If there is no apparent bleeding, you can see by giving balanced crystalloids if her BP and pulse settles. Otherwise, you may have to again give her PCVs, plasma and albumin. In practice, we should consider the 4 Ds of fluid therapy. That is, the 4 Ds, that is drugs. What drugs are we giving and what is the effect of that drug on creating a hypovolemic shock-like picture like tachycardia, hypotension? What is of the drugs that we are giving like oxytocin, carbitocin, prostodine, whatever we are giving? What is the dosing, the dosage of the drug, duration of the IV fluids that we are giving, and de-escalate. Once the patient settles, we have to quickly stop giving or over-infusing the patient. When prescribing IV fluids, we have to remember the 5 R's, that we have to first resuscitate the patient, then routine maintenance. Once she has come to routine maintenance, you may have to replace. If the hemoglobin is less, we have to give packed cell volume. If the platelets are less, we'll have to give platelets. So replacement. Then there is redistribution and reassessment. More than 60 kg patient, any patient who is more than 60 kg, on an average, even you have to give 2.4 liter per ml ml per 2.4 liters per day is a normal maximum amount of IV fluids that we can give. 100 ml per hour is the maintenance dose. That is, if the patient is not bleeding, you can continue the IV fluids at 100 ml per hour. So an entire 500 ml should go in about 5 hours. Now, some patients, in some places, the pack cell volume is not available. They get whole blood. A donor contributes whole blood to a bank, but this 1 unit of blood has a potential to eat 4 distinct blood products: the red blood cells, the platelets, the fresh frozen plasma, and cryoprecipitate. We can use this for 4 different patients at 4 different times and save 4 different lives. So, whatever whole blood donated 500 ml, we get about 200 ml of packed red cells and about 50 ml of platelets. The platelets shelf is 5 days at room temperature. We get 250 ml of plasma, and the shelf life is 1 year, and cryoprecipitate with the shelf life of 1 year, whereas the PCVs, the shelf life is approximately 30 to 45 days. And now, if we see this blood component therapy tells us that in 1 unit of pack cell red blood cells, you have 450 to 500 ml of, if there is whole blood, whereas you will get only 200 ml of RBCs, and the shelf life is 35 to 40 days. 1 unit platelets, it's about 400 to 500 ml of whole blood. You get 50 ml of platelets, and it has to be brought to the room temperature, and then platelet parameter increases by 10 to 20,000 for per unit platelets. 1 unit plasma and cryoprecipitate, similarly 250 ml and 15 ml we get, but the shelf life is 1 year, or thawing is required, and this can be used for other patients as well. Now, on an average, if there is a requirement for massive transfusion, we have seen various protocols. They normally give 6 packed RBCs, then 5 thawed plasma, 1 platelet, and then a cryoprecipitate if required. So coming to this here, if you see the blood component therapy, on an average 4-unit packed RBCs are given, and if there is a coagulopathy correction, then you add 4 units of FFP, a single dose of platelets. Repeat packed RBCs, FFP and platelets as required, and remember to administer calcium as appropriate in between these 4 packed cells that we give. So this is very, very important. One line I would like to talk about the off-label use of the factor 7A in obstetrics. Remember that there is high risk of thromboembolism, and we have to consider all the physical measures for thromboprophylaxis in this patient. We have to monitor all women for signs of improvement and adverse events, and report patients receiving the recombinant factor 7A to the hemostasis registry. So once we activate the massive transfusion protocol, if there is life-threatening bleeding, or the expected transfusion is more than one blood volume in 24 hours, or 4 units of pack cell transfusion within 4 hours. So as I discussed earlier, we have to give 4-unit pack cells, 4-unit fresh frozen plasma. Then second is 4-unit pack cells, 4-unit fresh frozen plasma. Then third is 4-unit pack cells, 4-unit FFP, 10 units cryoprecipitate, and then you have to go to alternate second and third line treatments, which also includes the recombinant factor 7A. That is, you have to give 90 microgram per kg if there is ongoing bleeding, or after second treatment with blood products, repeat after 20 minutes if no response, or every 2 hours if there is a partial response. All in all, what do we expect by giving this treatment? We want that there should be hemorrhage control, either a medical control or a surgical control, platelets more than 50 to 75,000, fibrinogen more than 1 grams. We have to prevent hypothermia, correct hypocalcemia, monitor coagulation studies, fibrinogen, platelets, and hemoglobin. So if you see in this particular slide, I'm sorry, it's a very busy slide. If the blood loss is more than 500 ml, the moment it has to ring an alarm, what you have to do is empty the bladder, put a Foley's catheter, administer first-line uterotonics. If the blood loss is more than 1000 ml, we have to activate the PPH protocol. The basic patient management to monitor and the temperature, pH, the calcium, give her oxygen, and hyperfibrinolysis, tranexamic acid, we have to give within 3 hours of starting of the bleeding. If there is fibrinogen deficit, then we have to correct the deficit by giving fibrinogen concentrate or cryoprecipitate. And if there is ongoing bleeding or if there is abruption, we may have to initiate the massive transfusion protocol, which includes a fresh frozen plasma. And if after PPH, the patient may need thromboprophylaxis, we may have to give low molecular weight heparin at 6 hours. And if there is anemia, then we have to treat her by iron supplementation after 1 to 2 days. So the control of PPH, it's not a one-pronged attack. We have to do it from multiple pronged attack. And depending on what the blood loss is, we have to add a newer and newer method so that there is better and better control of the bleeding. So what are the clinical endpoints? The clinical endpoints for successful resuscitation include maintain mean arterial pressure more than 65, sustained mental status. Patient is responding to your questions, answering everything properly. Urine output is maintained and acid-base status. Serum pH, lactate, base deficit, bicarbonate have all been extensively studied as clinical markers of resuscitation success and shock. Although there are many parameters to measure, lactate and its clearance is the most adopted surrogate marker of tissue perfusion. So the moment there is a PPH, please send lactate. And because the half-life of lactate is only 20 minutes, persistent lactic acidosis is indicative of persistent tissue hypoperfusion. Therefore, use of serial lactate have been useful in predicting the mortality in both septic shock and traumatic injury. Therefore, lactate levels should be initially collected at recognition of hemorrhage, and it can be followed during resuscitation as an adjunct to ensure the tissue perfusion while ensuring your hemostatic control. So what we see is the hypovolemic shock, then we give fluid in resuscitation. This causes intestinal edema, visceral swelling, then there is mesenteric vein compression, venous tension, oliguria. All this further increases the hypovolemic shock and fluid resuscitation, and this goes on if we don't detect the cause of bleeding and don't shut the cause of bleeding wherever it is. So what are the complications of giving excessive IV fluids and blood? During large resuscitation, patient can experience hyperkalemia from the RBC overload, hypokalemia from citrate which is there in blood products, and hypomagnesemia. During large resuscitation, serial electrolytes should be sent, and without repletion of electrocyte, the patient can have arrhythmias. Citrate can cause hypocalcemia. Severe hypocalcemia can even cause cardiac changes, dangerous arrhythmias like Torsades de Pointes. Remain vigilant for the overload, electrolyte abnormalities, and circulatory overload. And massive blood transfusion is replacement of the entire blood volume of 5 liters or equivalent or greater within 24 hours. The total volume is calculated as 70 ml per kg of body weight. So the complications are acidosis, hyperkalemia, depletion of fibrinogen, depletion of platelets, and hypothermia. A lot of other complications of massive transfusion protocol, TRALI, that is transfusion associated lung injury. Then there can be hypothermia, allergic reaction, hemodilution, thrombocytopenia, febrile reactions, electrolyte imbalance, and delayed, you can have hemolysis, transfusion transmitted infections, post transfusion purpura, and all that of that. So all in all, we have to remember that massive bleeding causes a vicious cycle of loss of consumption of coagulation factors and platelets, and massive dilution of the coagulation factors and platelets because we are transfusing fluids and blood products. Then this causes coagulopathy, which itself can cause hypothermia, acidosis, fibrinolysis, and vessel rupture and leakage. So we must know this pathophysiology. So I'd like to end with this particular card that is available at NHS, wherein they have, it is available at all with all the nurses, with all the labor wards. It is available everywhere on how to transfuse the blood and the blood products and what is the aim. If you see here, the yellow thing, the blood and blood components, they said that if blood group is O negative, we have to use whatever is immediately available, group specific, and then they have said the HB has to be maintained more than 8 milligrams. When to fresh frozen plasma, when to give platelets and cryoprecipitate, everything is mentioned and standardized, and it is used all over UK. So thank you for a very patient hearing, and I am happy to take some questions if you have.
explain the management of PPH. We have mentioned about crystalloid and colloid management. One thing I want to ask that you said that we can start with thromboprophylaxis in selective cases. So how many hours after this main incidence you start with thromboprophylaxis? And at what dose?
See, it depends. No, the thromboprophylaxis, it's a prophylaxis. So the prophylaxis is about 60 international units what we start. If the patient has completely stopped bleeding, you can start 6 to 8 hours after that, or whatever is it, depending on the patient's condition, whether she has undergone hysterectomy, obstetric hysterectomy, or some whatever any other surgical internal like ligation, whatever has been done. But then with high risk patients, diabetic, hypertensives, PIHs, elderly patients, it's always better to start thromboprophylaxis along, after this massive hemorrhage, because pulmonary embolism is one of the main problems with these patients later on. Pelvic veins, they are very much prone to thrombus.
Right. But many times we continue tranexamic acid also, and we have to start with this thromboprophylaxis also. So how to manage?
Highly
Because
patient dependent, but remember, we have to start a thromboprophylaxis in obese, hypertensive patients. Once they stop bleeding, then there is no role of giving tranexamic acid once they have stopped bleeding.
Right. Yes, madam. Thank you, madam. So madam has covered the topic very well and given us the guidelines about fluid and blood management in PPH. Over to you, Monica. Next session.
Yes. Thank you, Dipali ma'am, for chairing the session, and Geeta ma'am, elaborate talk.
Monica, can I make one announcement regarding our conference?
Yes, definitely, ma'am.
Yeah, Akola Obgyn Society has been organizing one conference on Ferticon 2024 in December 14 and 15. It's purely a conference focused on infertility topic, basic infertility topics. So, and almost 20 national faculties are coming from all over India. I'm requesting all the faculties and all the delegates to come to Akola and enjoy that scientific sessions. And we will be arranging very good banquet also, cultural night. So you all are invited at Akola. Monica, you too. Sneha madam, probably she is not there in India at that time. She conveyed me the message. But all other faculties and delegates are invited for the at Akola. Thank you. Thank you so much.
Thank you.
Thank you, Dipali ma'am. Geeta ma'am, wishing you all the very best for all your future endeavors.
Thank you.
And I request all of you to please vote for Dr. Geeta Balsapkar madam as the Vice President from the West Zone. Thank you, ma'am. It reminded me of my Vadia days, you and Amay sir both. Thank you. We move on to the next academic session. This session is by Dr. Sashi Kabra Maheshwari madam on PPH bundle care approach. Our chairpersons for today, Dr. Charutta Ranade madam. She's a consultant obstetrician at Ashwini Nursing Home, Yavatmal, and currently she is the president of Yavatmal Obstetrics Society. We welcome you, ma'am. Dr. Shalaka Adgavkar is a consultant at Ekbira Hospital, Akola, and she's been practicing in Akola since 2010. We request Charutta madam to please introduce Dr. Shashi madam. I think ma'am is not around, ma'am. I take the privilege in introducing you. Madam is the secretary of the Delhi chapter of the NIGF, chairperson of the Safe Motherhood Committee, AOGD 24 to 26.
Hello.
She's an yes, ma'am.
Yes.
Yes, ma'am. Ma'am, please.
Am I visible?
Yes,
ma'am, you're visible and audible. You can please go ahead with the
Good evening, all. I
yes,
first of all want to congratulate Akola OB-GYN Society for hosting this valuable program. I'm very grateful for the opportunity to chair this important session of PPH bundle approach. PPH is one of the leading causes of maternal mortality and morbidity worldwide. The most common causes of PPH include uterine atony, retained placental tissue, trauma to the birth canal, and coagulopathy. The management is early recognition and prompt treatment. So let's hear respected Dr. Shashi Kabra madam how to deal with this nightmare. Her just a minute. Where is I would like to introduce. Can you show me her slide?
Ma'am, her slide is being projected on the screen.
we can move forward, I think.
Where is it? 1 minute.
Ma'am, if you want, I can send a screenshot to your WhatsApp so that you can read it.
Please,
Yep.
please. Thank you.
Dr. Monica, we can move forward. There's no problem.
Yes, ma'am.
Just one.
Ma'am, please check. I have sent it.
Yeah, I got it. Yeah.
Madam's vision and mission is on
Dr.
prevention of
Shashi
maternal
Kabra,
mortality.
madam.
Yes, ma'am.
Yeah. Dr. Shashi Kabra, madam. She's a Secretary Delhi Chapter North India Gynac Forum, Chairperson Safe Motherhood Committee, AOGD 2024-26, Associate of the prestigious RCOG. She has won IMA Appreciation Award 2018, recipient of Wonder Foxy Award 2019, API Abdul Kalam Appreciation Award 2020, IMA Karamveer Award 2021, Champions Award, Obstetric Critical Care 2021, APJ Abdul Kalam Excellence Award in DGF 2022, Pride of North India Gynae Forum Award 2023, Vishisht Seva Mandal DGF 2024, Legend of OBGYN Award UPCOG 2024, Mentor Lakshya, Government of India. She's a member of Practical Obstetric Committee, FOXY, a North Zone Coordinator for Medical Education Committee, FOXY. She has organized 85 workshops on PPH all over India, patent right of teaching model on ILAI, inventor of Bharat Balloon. Over to ma'am.
Yeah, thank you so much.
Thank you, ma'am.
For such a kind introduction, and my sincere thanks to the Akola OBG Society and each and every member of Amogs for having me here. Hello, so is my slide visible, ma'am?
Yes, ma'am.
Okay. So my first request is that we think that many a times we think that postpartum hemorrhage creates nightmare. So you remove the word panic from your dictionary and convert your nightmare to your expertise. It is defined as estimated blood loss of more than or equal to 500 ml after vaginal delivery and more than 1000 after cesarean. And if there is a reduction in the patient's hematocrit level of more than 10% compared with the prenatal value, or there is blood loss which causes hemodynamic instability of sufficient degree to require blood transfusion. In both the cases, it is a postpartum hemorrhage. And early recognition, as Chairperson ma'am, you have already said, is very important. Now, when we look at the map of our country, then you see the incidence varies from 35 to 56%. We are talking about entering into becoming a developed nation by 2047. But where are we? So the development of any nation starts with the prevention of maternal mortality. That is my firm belief. And you see, obstetric hemorrhage constitutes to 38% part of maternal mortality in our country. So that's why we need to talk about, discuss, and rehearse the management and treatment of postpartum hemorrhage. It is the biggest and the fastest killer. I will tell you how it becomes the fastest killer. Ian Donaldson, a very famous obstetrician, said, while managing postpartum hemorrhage, time lapse should not be counted in a minute. One has not lost 1 minute, but 60 seconds. And in PPH, each and every second is important. Why it is the fastest killer? Because the uterine blood flow, the term is 700 to 800 ml per minute. And the women's blood volume is around 4.5 to 5 liter. That means if this patient is not treated in 8 to 10 minutes, it will lead to her death. So you have to be so quick. So the first 60 minutes are very important. That is called golden hour. Your delay this curve will be like this. The chances of survival of the women will decrease. So what is most important? It is time. It is again time. And it is again time. So patient should receive all treatment modalities, that is called PPH bundle, in 2 hours. First, I will discuss all the modalities, then again I will come for bundle. So this is the most important intervention for prevention of PPH. This is my only one slide on prevention of PPH, that within 1 minute of delivery, you give 10 units of intravascular or intramuscular oxytocin. And why it is so important, and that 1 minute is so important, because it decreases the chances of PPH by 50%. And then you must know how to estimate the blood loss quantitatively. So we are using these bags in our hospitals. A few of them are graduated, and even if they are not graduated, you can measure. And these are the different measurements, like Mogs, gauge pieces. So during cesarean, if you look at, have an idea of quantitative blood loss. Then this is the PPS toolkit of my own hospital, GTU Hospital, which is a 640-bedded hospital in the government of Delhi. And we have 10,000 deliveries per annum in our hospital. So this is the PPS toolkit with great sign on it. And it is kept at a strategic place in our labor room. So whenever PPH happens, we take out things from this box. It has a Bakri balloon also, a uterine component balloon also, sterilized. And whenever any part is used, we immediately replace it, because we do not know when the second PPH will occur. So this will save every seconds in the preparation. After all, it is a matter of time. So the kit contains IV cannula, gray. The answer is gray or orange, not gray. Then it contains vacutainer tubes, plain EDTA, fluoride, PTINR, then different types of syringes, then cannula fixers, catheters, Eurobag, distilled water, infusion set. There are 2 types of infusion set, one for blood transfusion, one for IV transfusion, seizures, swabs, Ringer's lactate, the fluid of choice, the crystalloid of choice, then 3-way connection, oxygen face mask, then sponge holding forceps, catgut, Vicryl, uterine pack, surgical gloves, antibiotics, and BP. We keep a separate BP apparatus and stethoscope so that we do not waste time. And NASD, I will talk in detail later on. And we keep the blood transfusion lab and consent form also in the box, so that that particular moment, not even a single second, not even 1/60th part of second is wasted. So let's talk about the cannula. You see, these are the different cannulas which are commonly available in our wards. And please don't use this cannula. Use the gray cannula, because orange I've never seen in my wards. This gray cannula, 16 gauge, use this. Why? I will tell you in the next slide. This orange cannula 14 gauge has the highest rate of flow per minute, and the gray has 236. So the patient of PPS goes suddenly into hypovolemic shock. So we cannot do anything with these type of cannulas. So this is required. These are small, simple things which you have to know. Now, why this 3-way cannula is very important? If you need to transfuse blood immediately, even the pressure bags on the blood bag will not work. You just use this 3-way cannula, draw blood from one side of the blood bag and push it with a 10 cc syringe to the patient side, and it will transfuse blood in 10 to 15 minutes. This is my own picture for a patient. In the hurry of managing PPH, we sometimes forget to keep the patient warm. So please warm the patient. All other assistants are busy, but I am busy in covering the patient to make her warm. Now, there are different types of rules, rule of 30 and rule of that, and this shock index also. Shock index, FIGO says that it is a marker of severe PPH. In normal person, it is 0.5 to 0.7. And in obstetric patient, if it is more than 0.9, then we call that patient is in shock. So, in that moment of hour, and in so much of panic, we usually forget the shock index. So just my simple advice. I do not tell you to, I'm not discouraging that you don't remember the shock index, but I'm telling you a very good practical tip. You just remember the rule of 100. This I have made. If the patient's pulse is more than 100, and if the systolic BP is less than 100, become alert. There is something abnormal, become alert. And give IV fluids. So this is the IV fluid of choice for all practical purposes. And how to identify shock, everybody knows. When tachycardia, irritable or unconscious patient, extremities are cold. Sometimes they may not be cold. Even then the patient may be shocked. Then urine output decreases. And we need specific instruments for management of shock, like uroflowmeter, ventimass, CPP line sometimes required. And Ringer's lactate should be we should use around 2 to 3 2 liters of crystalloid. So that means Ringer's lactate almost 4 bottles, because one bottle contains 540 ml. This is a very simple formula that when patient loses 1 unit of blood, then you give at least 3 units of fingers lactate. Sometimes our residents say, ma'am, this patient will go into hypovolemia and will go into pulmonary edema if we give so much of blood transfusion. So my teaching to them, to those students, is that this is a hypovolemic shock. This is not a chronic anemia. This is a hypovolemic shock. So you just rush the fluid, at least 2 liters of crystalloids. Nothing will happen to the patient. Hydroxystyrene starch should never be used in any obstetric facility. So those who have this, please throw it outside your obstetric facility. And the role of succinylate gelatin colloid has also been decreased very much. But still, if you need a colloid, then you can use it. But it's always better that after crystalloids, you give blood. So now I'm discussing one case. Her pulse, she is a 38-year-old gravida 6 para 5, just delivered her 6th baby. Initially, her pulse BP was stable, her hemoglobin 8 gram. She received prophylactic oxytocin. Even then, the resident found a gush of bleeding. Her uterus was flabby, that means atonic PPH, and her loss was 900 ml. For this patient, it is a major blood loss. Her pulse started increasing and BP started decreasing. So what to do? Alarm. Call everyone for help. Because our resuscitation, monitoring, investigation, and treatment, everything will go simultaneously. It's an emergency in the labor room or emergency OT. So call for help, call senior obstetrician and anesthetist, alert your blood bank or hematologist, and call consultant on call. You should always call the consultant on call whenever a PPH occurs. Keep managing the patient, but call the senior person. Then the 2 ABC, airway breathing circulation, give oxygen by 15 liters per minute. Fluid, I've already told you, give 2 liters of isotonic crystalloid, repeating again, at least 4 bottles of fingers lactate. And if there is a grave emergency, ma'am has said, you can also give negative blood or group specific blood. And I will not talk about blood products in details because that has already been discussed. So we have to put 2 14-gas cannula, not one, because through one we have to give oxytocin, and with the other one we will give IV fluids and blood products. Then send investigation, full blood count, coagulation profile, LFT, KFT, and ask for cross-matching. Then put a Foley's catheter. It will help in measuring the urine output and have an assessment of the fluid management of the patient, and also empty bladder always encourages uterine contraction. So, and then maintain the records everywhere above the uterus. Give our prophylactic drug for uterotonic is oxytocin, and therapeutic drug is also oxytocin is the drug of choice. Now we are giving it in 40 units and 500 ml. And if the patient is not responding to oxytocin, then we can give ergometrin 0.2 milligram, carboprost 250 microgram, or misoprostol if the patient has not received it for prophylaxis. Everybody knows the name of the drugs. The problem is what to do. So please read this line, move up the next step. If the patient is not responding, quickly move up to ergometrin, quickly move up to carboprost, quickly move up to misoprostol. Though the maximum recommended dose is very high. So don't wait for more than 5 to 10 minutes for any situation. So these are the fluid therapy and bed products. I'm not talking about these in details, already discussed. So now if the patient is not responding to all the uterotonics, then what? Then you see if the uterus is contracted and examine under anesthesia, rule out the traumatic part of PPH. And suture whatever traumatic part patient has, or take her to OT. Now, if the patient is still hemodynamically stable, then you can put an intrauterine balloon, you can give brace sutures, or you can do stepwise devascularization. But everywhere, remember it, steadily move up the protocol. These steps to be taken very quickly. These are parts of PPS bundle. So every maternity unit should have a multidisciplinary protocol for the management of postpartum hemorrhage, and all staff involved in maternity care should receive training in the management of obstetric emergencies, including postpartum hemorrhage. And the training for PPS should be multi-professional, and we should have regular rehearsals. I think every 1 monthly rehearsal is very important, and all cases of PPH involving a blood loss of greater than 1500 ml should be the subject of a formal clinical incident review, so that we can make some points after analysis how to prevent this in the next case. Documentation is very important. It will save you in the court of law. I will share with you a documentation chart, and debriefing to the relatives and the partners is also equally important. So I was talking to you about uterotonics. So you see, this is oxytocin. You mix it with normal saline or Ringer's lactant, and we should not give more than 3 liters of fluid. Then ergometrin, we can give maximum 5 doses. But as I have said, if the patient is not responding in 1 to 2 units and she is becoming hemodynamic unstable, please move to the next one. Don't stick to this 5 doses that every 15 minutes you will give. Because if you give every 15 minutes 5 doses, then you've already wasted 1 hour, 15 minutes. And the maximum dose for using carboprost is 8 doses. And that is to be given at 15 minutes interval. So here too, if the patient is not responding in 1 to 2 doses, then please move up to the next interval. Misoprostol will be effective only when we have not used for prophylactic. Otherwise, don't use this medicine. And this is very important, has been included now recently by FIGO and RCOG, all the major guidelines, that tranexamic acid should be given to every patient in a postpartum hemorrhage, irrespective of anything. You can take a screenshot of this chart. So the FIGO recommends administration of tranexamic acid as soon as the diagnosis of PPH is made, as long as this is within 3 hours postpartum. 1 gram of tranexamic acid intravenously over 10 minutes is to be given regardless of the cause of PPH if bleeding continues after 30 minutes or stops and restarts within 24 hours after the first dose. A second dose of 1 gram may be given. So in every case of PPH, you are giving tranexamic acid along with uterotonics. These are some temporizing methods which are very important for those obstetricians who are working in lower facilities. You can use this. You can use this direct vertical compression of the abdominal aorta. Even while operating, you can also apply pressure on the abdominal aorta. And this is the NAZ which I was talking about, non-pneumatic anti-shock garment. It maintains the blood pressure of the patient. And when you are transferring a patient from a lower facility to a higher facility, this will maintain the BP. And this part of the abdomen can be opened, and with that garment on, you can do surgery. So that is a life-saving garment. Tamil Nadu state has this NASG garment in all ambulances, and I think the government of India should make it compulsory for every state. We are also making it compulsory in our state, Delhi. So this is I have managed so many cases of postpartum hemorrhage in 22 years in my practice in such a heavily loaded hospital, and that's my experience, that there is not much role of conservative methods once patient has gone into shock and later picked up BP with this association. Suppose the patient has gone into shock due to PPH, then the role of conservative method from uterotonics to uterine press suture to balloon tamponade to internal alligator ligation, that decreases. The hysterectomy is the last resort in those cases. Remember it. Few cases may be exceptions, but remember this very important line. Always think of hysterectomy first in these cases, in those cases where the patient has already gone into shock. So after medical management, we have uterine balloon tamponade, and this is called mechanical method nowadays. And the two important prerequisites are that you have to rule out the traumatic postpartum hemorrhage because it will not work there. And second important point and most important point, remember it, hemodynamic stability. If the patient is hemodynamically stable, that means if the patient's blood pressure systolic is above 100, only then there is a role of uterine balloon therapy. If the patient's systolic BP has already gone below 100, please don't use this. People make mistake here, and that's why we lose life. So that's very important. So these are the different types of balloon. This is most commonly used in our country, and this is the Chhattisgarh balloon. This is Bakri balloon. Now, among these, the best is Bakri balloon, and Bakri balloon costs around 9,000 to 14,000 in different parts of India. Just sharing one thing, that I have invented this Bharat balloon. It is as good as Bakri balloon, and it is also made of medical grade silicone. And these are two things which are available. This balloon, this is the inflated balloon, takes the shape of the uterine cavity very well. And it is when I was thinking that why such a costly balloon should be available in India. Our Indian women, those who are delivering, most of them are very poor or lower middle class family, and even middle class family. So there should be such balloon which they can afford. So this balloon is like a drip set. You just see here. like a drip set. This is the balloon and this is a 50 cc syringe and this is a three-way cannula applied to it. And it can be used at every PSC, CSC, everywhere. And it is very cheap. It will cost around 1000 to 1500 ml. So every poor Indian woman can afford this balloon. It's not made for any commercial purpose, just for saving the women. So the specialty are this, that it can be inflated up to 500 ml. There is no drainage channel. That's why the cost is reduced. Because FIGO says that drainage channel is not required. And if there is bleeding even after intrauterine balloon tamponade, then we are not using that method. We are moving up to another method. It is etio-sterilize and compatible with drip set and syringe both. And a normal drip set or a normal syringe is available in every part of India. You just attach it to this three-way cannula and it will work. However, we are supplying the syringe along with this. So coming to other surgical procedures like brace sutures, transabdominal uterine artery ligation, internal iliac ligation, and hysterectomy. So this is a case where the women had atonic PPH and the balloon has failed. So when the balloon fails after uterotonics, then we move to brace sutures. It is recommended that a laminated diagram of brace suture technique be kept in theater and resort to hysterectomy sooner rather than later, especially in cases of placenta accreta and uterine rupture. And ideally, and when feasible, a second experienced clinician should be involved in the decision for hysterectomy. These are the different types of brace sutures. I commonly use these sutures, Bellin, Hamanchon. There are at least 15 to 20 types of brace sutures described in literature. But the best one are these three. So every obstetrician need not know every brace sutures. You just remember two or three and you become perfect in that. That is more important. So, there is a separate class for these brace sutures. So I'm just giving you a little hint. This is Lynch. This is Hemans. It does not require cesarean incision, can be done after vaginal delivery. And Chose is very good for localized bleeding. I use this suture after hysterectomy on a vaginal wall bleeding and it stopped the vaginal bleeding. The suture material used is Vicryl or catgut. Now, my one more key point, that in every case of anticipated abruptio placentae and placenta previa, you please open the abdomen with longitudinal incision. That will really make your life easy. In every anticipated problem, you do this. Then coming to step-by devascularization, we all have known about these pictures. This is uterine artery ligation upper and lower, and this is uterine ovarian ligation. Now, the word ovarian artery, I will come to ovarian artery later on. So I want to show you in this diagram that this is how uterine artery ligation is done. You have to take a part of the myometrium so that the lumen comes inside this circle. Only then blood loss will be decreased. If the incision goes like this, then it will not control bleeding. Same is showing in the longitudinal incision. Now, regarding ovarian, I wanted to say that ovarian artery ligation word is a misnomer. So remove this word, ovarian artery ligation. It is basically an ovarian uterine anastomosis ligation. Ovarian artery is here, direct branch of abdominal uterus. We are not ligating here, we are ligating it here. That is the anastomosis of the uterine branch of ovarian artery and ovarian branch of uterine artery. I have videos, in some other class, I will show you the video. Now, last but not the least is internal iliac artery ligation. This is common iliac, this is external iliac, continuous femoral artery, and this is internal iliac. This posterior branch gives the parietal supply and we ligate this anterior part because its major branch is uterine artery and this is the collateral circulation. And now FIGO recommends internal iliac artery ligation as one of the options to rapidly control postpartum hemorrhage for management when medical non-surgical approaches and compression sutures fail. And they recommend that all obstetricians familiarize themselves with the internal iliac artery location and with the technique of its ligation. This I was thinking since last 15 years. And I'm so happy that the FIGO has come up with this. We have saved many, many lives with internal iliac artery ligation in the past. And I made this model. This is a 3D model for teaching internal iliac artery ligation, teaching the technique and anatomy of internal iliac artery ligation. I think few of the doctors must have seen this in some conferences. And I'm glad to inform you that the government of India has given me the patent certificate for this model. And why am I mentioning uterine artery embolization? Because it requires 24 hours availability of radiological expertise and 24 hours availability of a dedicated OT also. That is at many places, that is at most of the places not available, and will not be available in another 20 years at most of the places. Either the radiologist is not available or the dedicated OT is not available. So please, friends, you learn internal allograft ligation. That's a good replacement for this. You can really save lives. Now, for any atonic PPH, we do a very quick subtotal hysterectomy. And if there is placenta previa or there is a traumatic hemorrhage which is involving the colpos or uterine artery retraction or rupture uterus, then we may have to do a total hysterectomy. So, resort to hysterectomy sooner rather than later and need to perform fast and rapid. Remember this one line, there is no use of saving the uterus and losing the mother. In order to save the uterus, very often, many times we lose the mother. This is one of my own surgery case where it was a case of placenta percreta, which is a new problem nowadays we are facing. And this is the last clamp of total hysterectomy. The placenta in situ with no attempt at removal of placenta. I've removed the uterus here. So this is the PPH bundle, which we discussed till now. And we should adhere to the guidelines. In summary, this is AMTSL I've already discussed, prophylactic management, then call for help. Then we do uterine massage, give IV fluids, give uterotonics, give tranexamic acid. Then supportive measures, we treat tears, empty bladder, empty uterus. Then refractory PPH interventions, compression, uterine balloon, anti-shock garment, and then supportive measures, blood transfusion, referral, and surgery. These are so many parts, components of the PPH bundle, and we have to finish in 2 hours, preferably in 1.5 hours. Confidential inquiry into maternal death was done many a times, and it is always found that either we do too little or too late. Too little fluid, too little oxytocin, too little blood and clotting factors, and too late decision for doing a hysterectomy and blood replacement, and that loses the patient. You please take a screenshot of this. This is obstetric hemorrhage chart, which I made with a lot of efforts, and it's really very good. It has been adapted from RCOG, but I have customized it according to our Indian designations and Indian scenarios. So just see, this chart will act as a checklist also, and as a documentation also, as I've discussed earlier. In the court of law, this will save you. When PPH happened, when did you call the obstetric SR, obstetric consultant, anesthesia SR, anesthesia consultant? When did you alert blood transfusion laboratory? When you called senior nursing officer and nursing orderly, you just write name and time arrived. Then when did you send the full blood count? When did you ask for cross-matching, coagulation screen, when the placenta was delivered? Just mention time, pulse, and BP. Then fluids type, volume, and time. Then uterotonics, oxytocin, when did you start? Ergometrin, how many doses, when did you start? Then oxytocin, infusion, when did you start? Then different doses of carboprost, when given? Tranexamic acid, when did you give the first dose? When did you give the second dose? Then oxygen, when did you start? When you started the IV cannula 1 or 2? And whether you transfer the patient to theater, then when did you put the intracranial balloon, tamponade, brace suture, interventional radiology, stepwise devascularization, internal iliac and hysterectomy. So this reminds you that these are the steps which you have to do in your PPH bundle, and this serves as a checklist, and this will save you for all medical legal cases. This is a PPH hemorrhage chart, obstetric wall chart it is called. I have taken it from GLOM, the Global Library for Women Health, a part of FIGO. And I have tested it in my own labor room at my own cost, because I think that every woman should be safe. And my residents in emergency, my PG students, my residents quickly see this, and every patient of PPH is managed. Presently, we have no death due to PPH in hospital, no death due to PPH in our hospital. That's a great achievement for our hospital. So my request for managing postpartum hemorrhage is take this opportunity to convert your nightmare into an expertise, learn every skill of managing PPH, save mother, save a family. Death due to PPH is completely preventable. It should be 0. Thank you so much.
Brilliant lecture, ma'am.
Charulata ma'am, over to you. Ma'am has.
Okay. Brilliant lecture, madam. You really have done incredible work on PPH. Ma'am, I just had one query about that Bharat balloon.
Yeah.
Is it available everywhere?
Madam, it will be very soon available. Give me 4 months.
And how much fluid do you have to infuse?
See, in almost all the cases, we require around 300, not more than that. But this balloon's capacity is 500 ml. And even Bakri balloon's capacity is also 500 ml.
Okay.
Look at the cost. That is 14,000. This will
Lot
be
of difference.
1,500 need to sterilize. I took 4 years in designing this balloon.
Great, ma'am. You really, congratulations. You really have done immense work on PPH and
Yes.
you make it sound very easy to handle. Hopefully, you'll be able to reduce that mortality in our state and our district as well.
It is doable, ma'am. We can do it.
Definitely, ma'am. Thank you.
Yes.
Over to Monica.
Shashi,
Thank you, Chair, ma'am.
always,
Yes, ma'am.
I mean, excellent as always. I'm proud of you, my dear. I know you have been working with me as press committee member and so many sessions together. And this also, even when I was a medical disorders committee chair and now an emergency obstetric committee, I have been including you purposefully for this because I want, as I always say that, hypertension, hemorrhage, and sepsis, these are the 3 major killers of our women.
Yeah.
We have to save our women from all this. These are the preventable causes of maternal deaths. And that is why I'm so happy to have you. Though I could not communicate with you personally because of my busy schedule, I'm very happy that, from the family vacation, you have been talking to all of us. So good job. Keep it up.
Thank you. Thank you, Dr. Sneha. Thank you for so much love and respect. I'm speaking from Nahan in Himachal.
Yeah, that is why I was telling. So
Thank you, ma'am.
Yeah.
Sashi ma'am, we would request you to just display the charts that you had shown in your PPT
Yes.
to share on the group so that we all can use it. And the second last slide, ma'am, which had the entire write-up, ma'am, for the benefit of all other members and the delegates who are attending this.
I will
We
share
can share
the
it,
whole
ma'am.
PPT in the group. I will share the whole PPT in the group.
Thank you so much, ma'am.
Because my purpose is to spread knowledge and to save every woman from PPH.
Thank you.
Thank you, ma'am. Thank you so much. It is always an honor to have you with us and a pleasure to listening to you. We now move forward with the next academic part, which is a panel discussion on near-miss cases. You have all, Geeta ma'am, and you have made it very easy for all our panelists to answer the questions. Our moderator for today's session.
Keep my introduction, please. Go ahead.
Yeah. The moderator for today's discussion is Dr. Sneha Bhuyar, madam, and we have a panel of experts. Dr. Bhupendra Patil sir is an associate professor, Department of GMC Akola. He has a teaching experience of almost 19 years and has several paper publications in state and international conferences. Our next panelist, Dr. Sushma Samir Deshmukh, ma'am. She has 9 years of teaching experience at a government medical college. She is the ex-assistant professor at Government Medical College, Akola. Currently, she is a consultant at Shukla Test Tube Baby Center. We welcome you, ma'am. Our next panelist is Dr. Priya Shuma Gawatre, madam. She is a consultant at Gawatre Hospital, Akola. She has been working as a senior resident at GMC and she has worked at Lidavati Hospital. We welcome you, ma'am. Our next panelist, Dr. Pallavi Thakre, madam, is an assistant professor at Sri VN Government Medical College, Yavatma. She is doing the junior residency at GMC, Yavatma, and she has many awards and honors to her credit. We welcome you, ma'am. Dr. Pratima Vinkare, madam, has a post-graduation from Grand Medical College and Third JJ Group of Hospitals. She has presented various papers in regional and state conferences. She has special interest in high-risk obstetrics, gynae and laparoscopy. We welcome you, ma'am. Our next panelist is Dr. Bharti Rathi, madam. She has received the Junior Talent Award in 1998 from the Aurangabad OBGYN Society, the best poster prize at the 16th State Amog Conference. We welcome you, ma'am. Dr. Anita Keshwani, madam, is the ex-registrar at Sri VN GMC, Yavatmal. She is practicing since the last 18 years and she has participated in various conferences. Her special interests include ultrasound, fetal medicine, and infertility. We welcome you, ma'am. Over to you, Sneha ma'am.
Yes, thank you so much, Monica, for the kind introduction of all our panelists. I welcome all of you, and I can see, the spectrum of panelists, right from our bachchas, Dr. Pratima Venkare, to the senior most obstetrician in our region, the Dr. Bharati Rathi. So, my dear friend, I welcome all of you. I hope you can see the screen. I'm just making it full screen. Yeah. So I welcome all of you. And without much ado, we would start with the panel discussion. Friends, you know what the title of this panel discussion is: near miss. You can see this picture is self-explanatory. You can make out the gravity of the situation and the urgency of intervention needed. No, nothing much can be self-explanatory. From the talks we have been getting, this near miss or severe acute maternal morbidity, how it is described by WHO. WHO says 8% of the SAMM in India is preventable. Okay, is 8% of the maternal mortality in India that is happening is preventable, and the responsibility lies on our shoulders. So, friends, we have been always talking about maternal mortality rates and ratios. So these are not just figures and numbers. These are women. They have their faces, and we obstetricians see them in the faces of their agony, distress, and despair. So these continue to haunt our dreams. I'm sure those who have experienced maternal mortality will not forget the face of that lady. So, over the time of the clinical times, one tends to forget the failures and take it for granted the success. But these are the failures which, stand out like keloids, keep on reminding you, and of course, warning for others. So I have already talked to you that SAMM is a preventable maternal mortality, and we have to work on that. I'm sure, considering the changing demography, the advanced maternal age, increasing obesity, a sedentary lifestyle, the smoking, alcohol leads to, infertility with increased ART IVF procedures, multifetal pregnancies, medical and surgical comorbidities, increased operative interventions, and of course, placental complications. All of you heard Dr. Shashi talking about, the increasing number of cesarean section and the associated complication. So you are just thinking that, this is a lady who is delivering normally vaginally, and in no matter of time, you find her in obstetric HDU or ICU. So friends, obstetrics is a bloody film, but unpredictable too. So life is the best teacher. Are you a good disciple? Never stop learning, because life never stops teaching you. So without much ado, we go to the first case discussion. We have this second gravida with previous one cesarean section. Last childbirth only 1.5 years back. She comes to you with 7 days overdue. You do her urine pregnancy test, that is positive. Now she wants to go for medical abortion. So the doctor prescribes medical abortion tablets, gives her necessary information. So ask her to come back after 7 days. So she just gets, on one night around 11 o'clock, she is collapsed at home, and she is brought by relatives to the hospital. When you examine, you find she's got severe tachycardia, blood pressure is only 70, pallor plus plus. So Dr. Bhupendra, I'm sure you must be managing these cases day in and day out in medical colleges. But just for the delegates, we want to discuss with you that what is your differential diagnosis here, what investigations you want to do, and how do you manage this patient?
Madam, in this case, hello.
Yes, Dr. Bhupendra, we can hear you. Please go ahead.
Madam, in this case, the clinical triad is present with a history of amenorrhea followed by abdominal pain with a severe spotting and pandemic shock. So the clinical diagnosis, probable clinical diagnosis goes in favor of acute rupture ectopic pregnancy.
Correct.
And the diagnosis is by sonography examination. And
at small peripheral town, you find that 11 o'clock, maybe even later, your patient comes in shock. So what is the feasibility, whether you can do ultrasound, whether you have ultrasound, if at all you consider the smaller nursing homes? What is your comment on this?
If sonography is available, then we will confirm the diagnosis and go for exploratory laparotomy. If the blood is available with
Correct.
fresh plasma, then we will go for the laparotomy at that
Yeah.
place. But
Yes.
if there is no sonography is available,
Mm-hmm.
we go for clinical history and examination, and again we do the internal examination. And there is an internal examination on per vaginal examination, cervical movement tenderness, uterine size must be made, uterus float
Yes.
as in. So again, these findings are goes in
Yes.
favor of.
Anything else to confirm the hemoperitoneum?
Again, cultosynthesis can be done.
Yes. Yes.
All
If
are
at all. I'm sure in medical college you can't even think of this, but you have a USC at your disposal. But yes, at periphery you may sometimes need this. So the investigations bedside was done. Hemoglobin was only 7 gram%. So you have come to the conclusion, ruptured ectopic pregnancy, acute rupture. So how do you manage this patient? Whether you would like to go for laparoscopy or laparotomy, and whether you would like to go for salpingectomy or conservative surgery.
In this case, we go for surgical management because already the patient is a hypovolemic shock. We go for a also.
Yeah.
Or
Surgical, but laparoscopy or open laparotomy?
We can go for laparoscopy also because if the blood is available and the fresh frozen plasma, then we can go for laparoscopy also and hemostasis or laparotomy.
But suppose she, because she's in shocks, I'm sure lots of blood inside. So whether it is difficult laparoscopically or how? What is your comment on this?
It is difficult because there may be chances of a hemoperitoneum because of the patient already in a hypovolemic shock.
Yeah, but then you can definitely see we have got nowadays lots and lots of laparoscopic surgeons. They say that you can easily suck out the blood and you can, catch hold of the bleeding point at the earliest. So definitely if you have an expert laparoscopic surgeon, you can go for laparoscopy. But otherwise it is, usually it is laparotomy because you can easily explore out everything and go ahead with the necessary surgery. What is the learning lesson here? Whether what do you think was missing while prescribing these pills, Dr. Bhushan?
Madam, first of all, the consent is to be taken, and the blood should be available at that. Blood should be available with fresh frozen plasma because the patient may be land up into diluted.
Dr. Bhupendra, what I'm trying to ask you, could you have been preventing this situation to occur? Whether this situation could have been prevented?
Madam, it can be prevented by before medical abortion. We go for the sonography examination and localize the pregnancy.
Yes. So only question here is whether it is a compulsion, whether it is mandatory to go for ultrasonography by law or how?
Madam, sonography should be done in this patient because sonography should be done in this patient. It is a mandatory.
Okay. So it is not actually mandatory by law, but it is recommended that for the safety of the patient and safety of yourself, we should go ahead for ultrasonography before prescribing the MTP pills or pills for medical abortion in any case. That is how it is. So thank you, Dr. Bhushan. It was a nice discussion. I'm sure people have received the necessary message. Now we go to the second case. We have this 36-year-old woman who, she's conceived with IUI. She's got a long-standing 7 years infertility. Husband stays in Dubai and she stays in village. But now that she has conceived on IUI, she's coming to her obstetrician regularly, almost up to 24 weeks, and the obstetrician conveys that things are normal. So she goes to the village and stays there. One morning, she reports to the PHC for pedal edema. When the doctor measures the blood pressure, it is around 176 by 116. Fetal growth and rest of the things, what is done at the PHC level, they have found it normal. So they just thought it is high blood pressure. They started with tablet, nifedip in the retard. And the patient was advised admission to the higher centers, but she did not go to the higher centers. She reported to the higher centers almost 1.5 days later, where her blood pressure was again 168 by 110. So they just added tablet labetalol to this, and because she may convulse, so they just started her on magnesium sulfate. At a sub-district hospital also, because the anesthetist is available, facilities for cesarean section are there. So they just go for cesarean section. delivered the 1.8 kg live female. Her blood pressure post-operative period still remains in the range of 140 to 180 systolic and 100 to 110 diastolic. So the patient is still on tablet nifedipine and Maxer continued. So after around 10 to 12 hours, the patient suddenly gets very severe cough, breathlessness, restlessness. She has tachycardia, blood pressure 220 by 118. Oxygen saturation is 70%. So, Dr. Sushma, what is your differential diagnosis? When you examine her chest, you find that it is all, noisy, no clear breath sounds. What is your diagnosis? Differential diagnosis, you can say, and how do you go ahead with the management?
Yeah, ma'am. In my slides, is given on second day after 30 hours of CS, patient had severe cough, breathlessness, and restlessness. Tachycardia.
What is your diagnosis?
So my on seeing slides, my first diagnosis will be elderly, para-1 living one with post-op day 2 of emergency cesarean.
Okay.
It's a 30 hours of cesarean section. Right. So it's
What
a
is the
day 2.
diagnosis? The precise diagnosis, 1 point.
Severe preeclampsia with pulmonary edema with acute pulmonary distress 1 and keeping in mind thromboembolism in the second AD.
Okay.
And now my management will start immediately because the patient is tachypneic and severe preeclampsia is there. So I will see whether the counseling of patient's relative is done or not about the preeclampsia, which is a multisystem disorder.
No, we talk about the management first. This is a catastrophe. So you tell me the management first. We will go to the introspection later.
Yeah, about the ICU management because I have to put this patient and shift the patient to the ICU.
But your patient has these problems in the ward. You have to manage it then and there only.
First of all, I will give the proper position to the patient. O2 mask, NIV plus. Then see whether quick thorough examination of the patient, whether she is catheterized or not.
Before that, don't you want to give her some drugs? 220 by 118 blood pressure. She is in pulmonary edema. Examination comes later on.
Yeah, but we should take the quick review about the 30 hours of cesarean section, what fluid have given, whether she's or catheter has been removed.
That we will be doing later on. That will not in the first minute. First minute, you just propped up, agreed, give oxygenation, agreed. Next will be giving the drugs. And what drugs? You tell me.
Yeah, furosemide 20 milligrams should be immediately given because BP is 220 by 118.
Actually, furosemide minimum 40 milligram for pulmonary.
40 in the drip. I will prefer 40 in the drip. And if the patient is exhausted before the pharmacotherapy takes place, then I will immediately shift patient because it is necessary to take the help of physician and intensivist, alert your team, and put the second cannula also. So investigation to see the effect of preeclampsia on other system also, CBC, platelet count.
That is what I exactly wanted to. That first step will be shout for help. You collect, all your team, whether you're not paramedics, your expert colleagues, whether anesthetists, intensivists, everybody. You try to seek help because you will need lots of help. Okay. Then what drugs you want to give now? Last 6 you have given 40 mg. What antihypertensive you want to give?
Yeah, but man, before that I have to resuscitate the patient first and send the investigations also. Serum electrolyte, see for the DIC also, chest X-ray, bedside, arterial blood gases, ECG, and call for the fundoscopy also. The causes of pulmonary edema, whether it is due to iatrogenic fluid overload with normal LVF or severe capillary pulmonary leakage.
Right.
And the treatment of this patient will include.
That is why there comes the role of CVP monitoring.
CVP monitoring. And in
consultation, you can have a look at this chart. Yeah, CVP monitoring, bedside echo, because that is how sometimes the peripartum cardiomyopathy also can manifest.
For non-cardiogenic pulmonary edema.
Yes.
Then D-dimer also investigation. And with physician, I will consult about the tape. I will tape up the antibiotics. Then I will decide about the antihypertensives, anticonvulsant prophylaxis, and thromboprophylaxis. These I will discuss with the physician because I will abet 220 by 110 BP is there. So I will prefer to IV Lobet.
See, now here I will tell you two things. First and foremost, she's already on magnesium sulfate. Okay, so she's not convulsing. She's already on magnesium sulfate. So her conversion part is already anti-convulsant is already started. Now, even though I have mentioned here injection labetalol, because we obstetricians are, very conservative, and nowadays rather than oral labetalol, because it's a very severe hypertension, we go for injectable labetalol. But if you concern with your, physician or cardiologist friend, for such a patient where you have pulmonary edema, they always prefer to go for NTG infusion.
Nitroglycerin.
Okay. Yes. So if at all you have your physician or cardiologist friend with you this time, it's always preferable to use for NTG infusion. Okay, go ahead, Dr.
If
Sushma.
that time patient is intubated, then I will prefer Maxelf or think about other anticonvulsant also, because it is a pulmonary embolism. Already patient is tachypneic, tachycardia is tachypneic.
Okay, so this, whatever you have said, everything was done. In spite of that, this patient developed cardiac arrest. They were just trying to manage their fatafat, whatever is possible, and try to shift the stretcher to the ICU. On the way itself, she developed cardiac arrest. Now you tell me, how will you manage this cardiac arrest?
Yeah, it is in the next slide, madam. The CPR is done. And
Dr. Priya.
Yeah.
Yes,
Dr.
ma'am.
Priya, you can take over. Yeah.
Yes, ma'am. The patient is a classical case of severe preeclampsia, which was lost to follow-up and which developed pulmonary edema.
We talk about the retrospection later on. Now
Yes.
that Sushma has brought your patient, she has managed up to this very well, but in spite of that, she's gone into cardiac arrest. So how will you revive? You have to revive your patient first.
Yes, I'll start resuscitation of the patient. I'll call for help with the physician on call.
All of them are there. All of them are there. Physicians.
Yes, fluid resuscitations with vasodilators will be started for the patient, and I'll suspect if the patient has cardiac arrest. We'll put the patient on ventilator support, and we'll suspect that maybe this is a case of pulmonary embolism post pulmonary edema. And
that we have done already. We have done her echo, XHS, ECG, everything. It's not in favor of pulmonary embolism. By the time you will be getting your laboratory reports also. Correct. So this patient was managed for CPR because you had your intensivist, physician, anesthetist, everybody. So as an obstetrician, we had no role but just to get it done. So things were done. CPR was given. She was put on ventilator, revived within 10 minutes, and her BP was 88 millimeter of mercury. Oxygen saturation, of course, came up to 90%. And slowly she recovered. But what went wrong for this management of this patient? Right from beginning, as an obstetrician, we do have certain responsibilities. So where things have gone wrong, and was it preventable?
Ma'am, the thing that I feel went wrong in this case was the patient was of severe preeclampsia and she was initially managed at PHC. We wasted a lot of time.
Priya, I will stop you here and I will ask you to go little back. Right from early pregnancy, do you think that something has gone wrong?
Yes, ma'am. The patient actually was staying in the village. She was following up with her gynecologist till 24 weeks, and after that she was lost to follow up till 34 weeks.
Still, here, see, elderly lady, you are only saying she was a case of infertility. She was conceived on IUI. So all these are very high risk factors, and such patient should be evaluated right from early pregnancy, right from right from history, whether she has hypothyroidism, whether she has history of family history of hypertension, and she should be going for the biophysical and biochemical test. Okay. So right from early pregnancy, the anti-scan, fetal shock markers, uterine artery pulsatility index. And of course, the SFLF and PGLF and SFLD.
PGLF, yes, ma'am.
Okay.
She should have been screened for preeclampsia early on.
And now once she is diagnosed as very severe hypertensive at PHC, 176/116, what should have been her management there?
she should have been immediately referred to a tertiary care center for
That they
further
have done.
management.
That they have
Yes.
done, but she did
And
not go.
yes, and she should have undergone blood investigations, which are usually done for the preeclampsia patients, her LFTs, RFTs, CBCs, and platelets,
Yeah.
and coagulation profile, along with rest of the investigations should have been done,
Correct.
and proper antihypertensive regime should have
Which
been.
was the proper antihypertensive that
Yes,
time?
injection labetalol should have been
Correct.
started for her. IV labetalol 20 milligram should have been given stat, which should have been repeated every 10 minutes.
If the
In
BP
this,
is not coming down.
yes,
Right.
yes, and
How much maximum you can give IV labetalol?
20, 40, 80, 80. This is the maximum
Maximum.
dose.
Maximum dose in 24 hours. How much?
24 hours, ma'am. We can give
300 milligrams.
300.
Give up to
300
300
Yes,
milligrams.
yes.
Okay.
IV
So
labetalol.
as you have rightly said that she was not screened properly. She should not have been missed for follow-up because she should have been counseled properly that you are a high-risk patient.
High-risk
Then
patient,
she should have been treated properly at the first point of contact where she was diagnosed as hypertensive, and then LSCA should not have been done at the sub-district hospital. It should have been
Exactly.
at the
Yes.
tertiary care center.
Where
Correct?
obstetric, HDU, and ICU were readily available with a team of experts
Right.
to manage the
Right.
complications.
Yeah. Any comment on the preload before giving anesthesia? Because we
Ma'am,
always give preload to the patient, fast IV fluids, running drips before spinal anesthesia. So for
yes,
this
but
patient,
in patients of preeclampsia, we usually monitor the intake and output chart very strictly. And the preload should be less. Actually, restricted fluid intake should be there in preeclampsia patient. And in postpartum, till the whole postpartum period, we give usually only 2 liter cumulative amount, and not more than that. That is monitored according to the urine output of the patient.
Okay. So first and foremost, she should not have received the preload very fast. It should have been, at a slower rate. That is one. Secondly, she should not be given the oxytocics like methergine or carboprost. Okay.
Yes.
Because they are the ones which squeeze the blood and, put load on the heart. So
Yes.
carbetocin is the best drug. And of course, the moment that baby is delivered, she should have received injection Lasix.
Lasix, yes.
Right. Okay. So these 3 precautions should have been taken.
Yes.
So thank you, Priya.
Thank you, ma'am.
That
Thank
was
you.
wonderful discussion, and I'm sure people have understood what has gone wrong. We now move to the next case. I'm sure there are many, many interesting cases, and I hope all of you feel that such thing has happened with us, and this type of patients come to us quite often, right? So, Dr. Pallavi,
Yes,
we
ma'am.
come to you now. Yeah. So we have this, 20-year-old young lady, primi gravida, with 9 months amino. She was, she was admitted at some smaller nursing home, and she was in labor from 3 p.m. to 11 p.m. So she was having very strong uterine contractions. Her vitals were stable, but she was not progressing. So they decided to take her up for cesarean section. So the sister catheterized her. There was no urine output. So she inquired retrospectively. Over the last 8 to 10 hours, she was not passed urine. Okay. So there was almost, like no urine over that 10 to 12 hours. So they got scared, and they referred the patient to the higher center. This patient, when came to the higher center, she was having pulse rate of 110, BP 110/70. Uterine contractions were so severe that there were no relaxation in between. The fetal heart was 100 to 120, and I'm sorry, this dilatation is not 7, but it is 3 centimeter. Membranes were absent, station 0. That means there was not much of dilatation in spite of the severe contractions. This patient, what will be your clinical diagnosis? Please let me know first.
Okay, so from the history, ma'am, she is 20-year-old primi gravida, term gestation, and we can see that she was having labor pains 3 to 4 hours before the admission. That
8
is
hours. 8
yeah.
hours before the admission.
Okay, 8 hours before the admission.
3
So roughly,
to 4 hours at home, 8 hours
yeah,
in a small nursing home.
right,
That
yeah,
is 12 hours.
exactly, ma'am. So 3 p.m., 3 to 4 hours before, so since 11 a.m., she was having strong uterine contraction, and now she came to us at 11 p.m. and still she is having strong uterine contraction. So it's almost period of 12 hours with strong uterine contraction, and still her station was at 0. Sorry, ma'am, but I received the PPT with 7 centimeter. So with that only, so cervical dilatation and the station is not according to the uterine contractions. Again, we can see that she has not passed the urine after catheterization. There was no urine output. So from that we can make out that even with the catheterization, there can be two things: either she was in severe dehydration, so that there was no urine output, or the urethra was compressed in between two bony parts, that is the pubic symphysis and the presenting part, leading to there was no urine output.
Yeah, but let me clarify you that, the catheter was negotiated well. It has reached urinary bladder. Still, there was not even
No
a
urine
single
output.
drop of urine. That is one. And secondly, I think you are missing out something during the
ma'am. So
examination.
now, then seeing towards the investigations, her HB is
Uterine
8.
contractions. We are still on
Uterine, uterine contractions were severe and there was no relaxation in between. Very importantly. And then the
What is that? What is that? What does that mean?
That is tonically contracted uterus. There are no in between relaxations. So it is going towards the tonically contracted uterus.
Yeah,
Now,
so what is the reason for that? What is the diagnosis?
So from here, I can make the diagnosis that she was primary gravida term gestation. Now in obstructed labor.
That word itself tells you. Tonic uterine contraction, no relaxation in between, and fetal heart going down. It is probably a case of abruptio placenta. Okay.
Yes,
Yeah. So you remember, no relaxation in between. Hypertonic uterine contraction is one, or they can be abruptio placenta.
Abruptio placenta.
It was little tender. Okay. So I have mentioned, So the investigations were sent, and you find that the investigation says that HB was
8 gram HB,
platelet was 1 lakh.
PTINR was 2.
Prolonged. PTINR was 2. And fibrinogen degradation products were present, whichever normally it is not supposed to be present. And fibrinogen was only 150%. Now you tell me what is the complete diagnosis.
So from the diagnosis for this patient is, ma'am, primary gravida, term gestation, mostly a case of abruptio placentae with early changes of DIC, because we can see that her coagulation profile is deranged, and normally
what about fetal distress?
With fetal distress, ma'am. Yes, ma'am. With fetal distress, because her heart rate is 100 to 120.
Yeah. So now let me ask you, on one hand, you have fetal distress. On the other hand, you have the maternal condition, which is worsening. So for fetal distress, because placental abruption, placenta is getting separated. If you wait, you will lose the fetus. Will you take this patient for cesarean section immediately?
Ma'am, first 3 things I will see. First, my aim would be general condition should be stabilized. Secondly, I'll rule out the sepsis, and then the obstetric management. So I will do the primary resuscitation. That is, we will achieve the IV bore cannulas and start the RL, make the blood and blood products available, see for if all the FFPs and cryoprecipitates and all necessary products are available.
Okay.
Then
So
also
once again, I ask you a clear question, whether you will take her for cesarean section immediately, or you will wait for the blood and blood components.
Her HB is 8 gram and platelet is 1 lakh. So here, if that is the condition, I will immediately take her for LACS. Because the one thing we have to do is immediately we have to take out the baby, so that the worsening of patient could be avoided. So I will take her.
Yeah, so that will help you in both the ways.
Yes, fetal and maternal condition also.
You will deliver the baby. Secondly, once you remove the placenta, the abruption delivery interval, which is very, very important. If at all you keep the separated placenta inside, the DIC will worsen. The coagulation parameters. So very good, because these are not very severe, severely hampered parameters.
Exactly, ma'am.
You can definitely go for. Yes. So just do fluid resuscitation for this patient. Take her for sedation. Once you're sure that you are getting the blood and blood products. Okay. So you have to manage the abruptio part, the labor part. You have to do. Now, what about the anuria? I was telling you aggressive fluid resuscitation. You have just heard the talk on fluid resuscitation, right?
Yes, ma'am.
So aggressive fluid resuscitation. I'm sure you were there.
Yes, ma'am.
Give it in fast fluid.
Yeah, 3 liters. Like we can give aggressive fluid management, like 3 liters of fluid we can keep ready for her till the blood products are available. And as ma'am said that for one whole blood, 3 fluids we can transfuse accordingly according to availability of the blood and blood products. Along with that, we will also see for FFPs, platelets, and cryoprecipitates, because her fibrinogen level are decreasing, and we will see the sequential level of fibrinogen so that we can know about the worsening and number of cryoprecipitates, further blood products to be needed for the patient.
Correct. Pallavi, I would just ask you why I am stressing on the aggressive fluid resuscitation.
Because
For
now
this
the patient has
particularly.
Because her BP at present is 110, which is she is quite stable, and if we aggressively manage her and avoid going her into hypovolemic shock, patient's prognosis will be
So do you
drastically
think that
improved.
she is in shock? That is what I want to ask. 110/70 is her blood pressure, but she is not having urine. Okay, so
yeah, and
the
her
very
tachycardia
fact,
is there.
yes, the very fact that she has landed up into abruptio, she may be hypertensive.
Yes.
And because of the blood loss, she has come down to 110/70. So you, unless you correct the hypovolemia, the kidney function will not improve and you will not get the urine. Okay.
Yes, ma'am.
So aggressive fluid resuscitation
is
followed by correction of the renal function. That is how. I'm sure all of you know the grades. Only what important practical points I want to tell you that you have to not only correct the hypovolemia, but also, you know, by giving aggressive fluid therapy, you correct the renal ischemia, you improve the renal perfusion so that, you know, the renal function is improved and you get the urine output. Otherwise, now the patient is in reversible, what is called as
shock, reversible
shock also, and what is acute renal failure, which is tubular necrosis. If you don't correct this hypovolemia, she can go into irreversible renal failure, what is called as cortical necrosis. Okay, so very well done, Pallavi.
Thank you.
Everybody is now motivated to think on this line. If at all now this patient you have managed and you know that she's going into DIC, and you said that time to time you have to go for the clotting factors or, you know, coagulation profile. So how frequently you want to go for coagulation profile for this patient?
Ma'am, fibrinogen, after giving cryoprecipitate, one cryoprecipitate will increase it by 10. So the life of fibrinogen is like 20 minutes from the what I remember. So we can, if the patient is improving, then it won't be like so frequent. But if patient is not improving, then we have to repeat at least by coagulation profile by 4 hourly, maybe, ma'am. Not very sure about it.
If it is not worsening, you can see that it is not very severe. Maybe after 6 hours, you can repeat once. You find that it is a rising trend. That means it is improving. You may just repeat it after 24 hours. Okay. So there is no need for frequent investigation. I'm sure all of you know what you have heard about the massive transfusion, blood transfusions and everything. So all of you know what blood component you need to give when. Okay.
Thank you.
So yeah, thank you, Pallavi. Now we come to Pratima. Pratima, we have this 32-year-old para 1 previous cesarean section, male child that is only 1 year old, and now she, you know, she comes to you for the first time during her 6 months of her pregnancy because her husband is transferred to your place, and she reaches to your hospital. The bleeding stops. When you examine, you find that, you know, she's got an old report showing low-lying placenta, and when you inquire, she says, yes, there was an early pregnancy spotting sometime earlier. So at this point of time, you do her ultrasound, you find that placenta is low-lying and absent RP leg, and yes, there are some hypervascularity, vessels running from lower uterine segment to bladder. Anomaly scan is good, normal. Okay, so you just see that, you know, she's not bleeding. So you sent her home. At 30 weeks again, she gets bleeding at home, and the moment she reaches hospital, it stops. But you say that, you know, oh, repeatedly she's getting bleeding. So you investigate her in details again. The moment she goes for investigation, you know, she bleeds profusely and she collapses. What is your diagnosis, first and foremost? How do you manage this patient?
Thank you, ma'am. The diagnosis of the patient will be gravida 2 para 1 living 1 with previous LSCS with 30 weeks of gestation with placenta previa with placenta accreta spectrum in bleeding phase.
Yeah.
For the management of this patient, first we'll have to do the immediate management for her. We'll admit foremost we'll admit her. Then we'll do the general examination of the patient. We'll look for her pulse, blood pressure, urine out pallor. Then we'll do the perabdominal examination to see if the uterus is contracting or is irritable. We'll also look for the fetal heart rate.
Yeah, I'll just
Then
interrupt you. Sorry, I'll just interrupt you. Pratima, I'm saying the patient is collapsed. So will you examine her or will you start IV fluids from both sides and start her on IV fluids?
yes, ma'am. Then we'll do Foley's catheterization for her. We'll put 2 wide bore cannulas for her and we'll start IV fluid management and we'll arrange for blood products. Almost 4 to 6 units of blood need to be arranged at that time. Since the patient is now significantly bleeding, we'll have to take her up for emergency section regardless of the gestational age, and the section needs to be under general anesthesia.
Okay. What do you feel that what will be the surgery necessary for her?
For this patient, first of all, since we already know that it is a placenta accreta spectrum, so we'll have to be prepared that she might need hysterectomy. So, if intraoperatively, if there is just focal placenta accreta, we'll try to manually.
Before this, you need to counsel the patient and relatives. Okay.
Yes.
Young lady, you cannot directly go for hysterectomy. Rather, the moment you diagnose placenta accreta, you have to go explain them that what will be your plan of management. Okay. So how do you counsel the patient that what type of surgery, whether it is cesarean section or what type of surgery, and how will you take the consent?
Ma'am, the relatives will have to be explained that that if we are able to save the uterus, we'll do that. But in a situation might come where we'll have to remove the uterus to save the life of the patient. So that will have to explain to the patient, to the relatives that it is important to save the patient and not the uterus, and hence we'll take the consent for hysterectomy.
Yes. There was a time when we used to say, that whenever you have placenta previa accreta, you have to go for elective obstetric hysterectomy, just maybe 3 to 5 years ago. Okay. But nowadays you have the options available and people are very well trained in now the conservative management of the accreta spectrum, right? So that's the reason we can just tell them that we will try our best, but this is the standard management. Okay. Otherwise, if you intraoperatively, if you go and talk to the patient and relative, they will say that you have spoiled something or traumatized something. That is why now you have to go for hysterectomy. So the informed written consent has to be pre-operative, right? Okay. What else you want to take in the consent, considering this patient, collapsed patients?
The patient will need critical care management. She'll have to be admitted in the high dependency unit.
Maybe shifted to ICU, and the patient we may even lose the patient. That is how the consent should be. Okay. Now, when you want to go for surgery for such patients, you have already diagnosed, you have already arranged for it. Now, I will just say that if at all you diagnose such patients, what should have been? Now, see, this patient was diagnosed as accreta right from early pregnancy, even at 26 weeks. Leave the early pregnancy. 26 weeks, you have placenta previa accreta. What should have been the management then, that time? She has already bled 2-3 times.
At that time only the patient should have been advised for detailed sonography. Then or else she should have been advised MRI.
She has done already. She is a diagnosed case of placenta previa accreta. I'm telling you. Correct? It is seen there. So whether she should have been admitted that time?
Yes, ma'am. She should have been admitted at that time, and she should have been advised regarding the complete bed rest. She should have been
pelvic rest at least, not bed rest, but pelvic rest.
Yes,
okay, pelvic rest is not to sit down, not to go for strenuous work, and not to go for intercourse or internal examination. Okay, and the informed written consent should have been right from that time. That even though we try our best, this patient is a potential danger and she can land up into catastrophe any time because the placenta is low lying, nobody can stop her from bleeding. Okay, and her blood and blood products should be reserved all the time. Okay, so that is how it is. So diagnosis and of course informed written consent. So if at all you have to, now you have already told them. So how you should have taken this patient, whether elective or waited for this emergency, how? Suppose nothing happens, this patient continues. Then when will you take her for cesarean section?
Ma'am, the best course for her, the best time for her to be taken up for cesarean section would be somewhere between 32 to 34 weeks, because at that time the fetal maturity can also be attained, fetal viability can also be, baby can also be taken care of. And
so I will not agree with 32, but definitely if she allows up to 34 weeks, right? And then meanwhile, you prepare her with magnesium sulfate and steroids, right? So 34 weeks is the ideal time. Suppose she doesn't bleed, you can wait up to that and post this patient for elective seizure. Okay, informed written consent for obstetric hysterectomy and all this. Now, you should take this patient for elective surgery, not as emergency. Now, why it should be elective?
Ma'am, because during elective hours, everyone will be well prepared that they have to come for the surgery. All the senior faculty of obstetrics, of anesthesia team, of the surgery team will be available.
Correct.
And if at all there is need of more blood products, that also can be arranged in routine elective hours.
Correct. Okay. So, what are the special precautions, Neetu? Dr. Neetu Keshwani?
Madam, my slide is missing.
Yeah, I will come to you, Dr. Bharti.
Okay, okay.
Retrospectively, I will ask you.
Okay.
Do we have Dr. Neetu?
Yes, madam. Madam,
Yes,
as
yes.
this patient is a case of placenta accreta, and we will take for elective surgery. So we manage with the help of expert team, that is a senior consultant, obstetrician, senior anesthetist, and vascular surgeon, and an interventional radiologist with neonatologist. With all this team, with the arrangement of blood products, we can. These are the special precaution we can take.
Right. And what are the precautions for, I mean, what incision you want to take? Abdominal incision?
Abdominal vertical incision should be taken, madam.
Okay. And what about the uterine incision?
Uterine incision should be also classical incision.
Yes. What else? Any other type of incision? Classical vertical, what is called as transfundal, that is transverse fundal. That is also okay, because you know you can easily deliver the baby.
Yes, ma'am.
Right?
Yeah.
So now your incision should not cut the placenta.
No.
Now once you deliver the baby, then how do you proceed?
We should leave the placenta. And wait for the wait with the monitoring with US and we should leave in case of placenta accreta, we should leave if it is not bleeding. And after closing, we will monitor with beta ECG and USG monitoring.
You mean to say you observe the placenta in situ, you leave behind the uterus? Is it? Is it?
Otherwise, we can cut the placenta and reconstruct the uterus.
Yes. So previously, see, when we were the residents, we used to keep the placenta inside, and we used to give methotrexate injections, higher antibiotics, but it was, all the time hanging sword, on your neck. So it is like, the potential bomb, we can say. The patient used to go into septicemia, secondary hemorrhage, torrential hemorrhage, and the hysterectomy, when required that time, used to be horrible. Okay. So nowadays, that concept of leaving behind the placenta is gone. The evidence says that you should remove the uterus. That is one, that is obstetric hysterectomy.
Yes.
Secondly, if at all the patient is not bleeding, secondly, if the patient is not willing for hysterectomy, then you have certain conservative procedures. So what are the conservative procedures? Anybody can take up this. Somebody wants to speak? Pratima?
Ma'am, for conservative procedure, we can try giving her methotrexate.
No, that too I have said that evidence doesn't support.
Here,
we
it
can
doesn't
try
support.
uterine artery embolization for her.
Okay.
And then these days
Conservative
preoperative.
surgical approach for this placenta accreta. See, previously we used to say that remove uterus. Nowadays, there are certain conservative procedure. One is triple P procedure. Triple P, 3 Ps. That means you map the placenta. That is first P. Second is you go for stepwise pelvic devascularization. Means
yes.
you
Internal
stepwise pelvic
internal
devascularization.
ligation.
And third is, as Neetu said, what is called as patchy resection. Okay, you cut the myometrium, you resect the myometrium, and you close it again.
Yes,
okay, that is the triple P procedure. That is one. And second is you close occlude the both the uterine arteries right from the origin, from both side, what is called as and also the descending cervical, that is called as Comog MG stitch. Okay, so you take those stitch, make the uterus totally avascular, and then you dissect out the placenta, remove it. It doesn't bleed much. If at all it bleeds, you can take care of it definitely. So that is also one of the measures of conservative surgical management. Then you can close the the incision of the cervix, and of course you have the compression sutures and all these things if at all she bleeds. Okay, so these are the conservative surgical procedures for placenta previa accreta. So what I'm trying to tell you is once you diagnose placenta previa, when you suspect when you suspect that it is accreta, so usually you can diagnose this as early as 16 weeks, even before that 11 weeks also. Okay, so what whether you need to have MRI or you can diagnose on ultrasound. That is my one more question to Dr. Bharati. We can go for the next discussion. Dr. Bharati.
Yes, madam.
Yeah.
Yeah,
So
am I audible?
I'm sure, Bharti, your experience will be of tremendous help for everybody. Please let us know whether you go for MRI always for placenta previa accreta, or we can very well diagnose it on ultrasound alone.
Ultrasound alone can give it the diagnosis also, and also the second trimester alpha fetoprotein levels, they are very much increased in the case of placenta accreta spectrum patients. So always, if you have a suspicion in the first trimester ultrasound, if you see the sac is in the lower cavity, lower at the level of the previous scar level, and it's more towards the anterior wall, so have a suspicion. So index means high suspicion index is very, very important for the obstetrician to manage such cases. And always in your obstetric unit, have at least 2 of your best obstetrician friends who are equally compatible with you. So you always can call them. They are competent friends,
as well.
and
Whether she is
2
junior or
anesthetists,
senior, no
2
problem.
intensivist friends. So this is my team always there. So I just ask my sister, call for help. She will call all these 6 people. 2 intensivists, 1 anesthesiologist extra, and the 2 obstetric friends. And if required, then the hematologist and means for the extra staff, because so many times in our private units we don't have adequate staff for managing such patient, and they are, even though we manage to keep this staff, but the staff, you know how scarcity, because even if they get 500 rupees more, they will go everywhere. So you should have 2 staffs always available with you, to whom you can contact for the assistance every time.
Yes.
So this is the basic management for the, all these things. And also, when you have had a suspicion of index that this patient is a case of accreta management, recently we had, and I'm very glad to have Dr. Patil here, Bhupendra. He is one of my hand for every time. Recently, in the last month only, we did one previous 2 LSCS with placenta accreta in the hospital. And that time again, the problem was whether to deliver this patient in my own hospital or at the ICU center, where the ICU is available. But in the ICU center, so many times when you take these patients, you don't have those obstetric OT facilities available. That is the main criteria which is needed for the obstetric hysterectomy or the internal ligation, because they are not well versed with those things. So those drugs are even for the oxytocin. If I'm doing this case in Ozone Hospital for the oxytocin, they will give a slip from the OT and they will ask to bring the oxytocin. So adequate of the oxytocins even are not available. So you call all your friends in your obstetric hospital. When you are managing any of the obstetric, you should have defib with you. You should have the central oxygen with you. You should have even the cardiac defib along with the defib. You can have the even I have all the resuscitative, even the ventilator also in my OT. Because when you are doing laparoscopy, you should have ventilators with you. You never know at what time cardiac arrest or ventilator need will be there. So manage this patient in your hospital. But with the consent of the patient, with the information to the patient, all these things are there from the 26 weeks of gestation. So you have to counsel that time itself. And you have to, because for this patient also, which we operated last month, that diagnosis was done at 26 weeks at some other hospital. And that obstetrician said, I cannot manage this patient. Therefore, they came to me. So that time only I prepared that patient for this emergency. And therefore, we could manage it very well and she's very good now.
Yes. So the message is very well delivered, and I'm just trying to sum up. So first and foremost, the message is you don't need to go for MRI at all the times for diagnosis of placenta previa or placenta accreta. In fact, the expert sonologists with good resolution sonography can, diagnose the placenta accreta spectrum to the best. Only thing is, when you have to go for the conservative management of this placenta accreta spectrum, when you have to decide the depth of invasion, then maybe, and of course, a very morbidly obese woman or maybe the posterior placenta, there you may have to go for MRI. That is how it is, and ultrasound can be the best diagnostic measure. Secondly, as Dr. Bharti has very nicely said, there should be a teamwork. You must have a multidisciplinary team always at your service. And of course, you must be able to do the delegation of work. Your staff, they are not expert, but they should be expert in communication. They should be able to gather the team which will help you. So very nice, Dr. Bharti. And now
here again, I would like to tell my juniors if they are listening, because always please go for the Manyata and Laksh program because Foxy is really thriving hard for these programs, but obstetricians are not at all responding so much, which is really a need of a time. And you should have your all the staff so trained with the Manyata and Laksh, because then they are on their toes. They know what to do for the PPH. Head side, I want to do this. The arm side, I want to do this. Leg side, I want to do this. So PPH management becomes very easy. Your obstetric management becomes very easy.
Not only the Manyata training, but the regular assessment,
drills also,
re-evaluation, retrainings, and of course the mock drills, that you imagine that such and such patient has come and how you will act, who will do what. That is how the infrastructure, the manpower should be ready. Okay, so Bharti, we come back to you now. Whether this catastrophe, this patient collapsed and you have to go for emergency surgery. So whether this was preventable right from early pregnancy because she was having placenta previa, whether you wanted to go for prophylactic os tightening, should we do it or no?
Madam, prophylactic os tightening has no role, because
absolutely the message has to be very clear. The message
cerclage is invasive procedure. Always remember, cerclage is invasive procedure and it carries its risk, and therefore routine cerclage has no role in the case of placenta previa. It's not at all justified.
In fact, the message here is that os tightening is not to be done prophylactic for anybody. No. It's to be done only when indicated, when you have the evidence supporting that, the cervical length is less than 2.5 centimeter. And of course, FIGO says that even for less than 2.5 centimeter, the vaginal micronized progesterone and the cerclage, they have equal cost efficacy and safety as well. So for this patient specifically, no for cervical cerclage. Any role for tocolysis, Bharti?
No, madam. Tocolysis, what bleeding in the placenta previa causes contractions, and the contraction, it increases the cervical effacement, and cervical effacement again give rise to the placenta previa bleeding. So this vicious cycle goes on.
Yeah.
So therefore,
there are no contractions here, so there is no role for
no role of tocolysis.
Correct, correct. What precautions we should advise to this lady when she was diagnosed? What precautions should have been advised? You know, they are
Actually,
missing.
she should, when she is a case of, and from the remote place she is, so she should have been admitted, because with the previous one history of actually cesarean section, there are chances of placenta accreta spectrum or the percreta or increta also. The 24% chances of placenta percreta it's given, and if the cesarean section previous number are increased, the placenta accreta spectrum increases the incidence. So therefore, these patients should have been advised from the 26 weeks of gestation itself. Even if she is not affording, then you ask her to go to the periphery, to admit in the general hospitals, in the medical colleges, wherever they are.
Go to the government
colleges. Yes.
Yes, right. So, Dr. Bhupendra, we come to you. Now that everything is well managed, but sometimes, you know, in spite of doing everything properly, you know, Bharti, you were talking about managing that patient placenta accreta spectrum very effectively. We are very happy. But sometimes these patients, you know, go into coagulopathy after you remove the placenta. Okay. In spite of everything, the patient keeps on bleeding from anywhere. Sometimes, you know, people advise go for the internal iliac ligation first and then go for hysterectomy. So suppose it happens with your patient, she goes into DIC, how will you manage? Dr. Bhupendra.
Madam,
Blood components and how much?
Madam, in this patient, that the patient goes in a coagulopathy, that is more common is a disseminated intravascular coagulation. First, we diagnose clinically that presence of epistaxis, oozing or hematuria, postpartum hemorrhage. And again, this diagnosis is confirmed by investigation. There's some bedside investigation, for example, the bleeding time, coagulation time, which is raised. Again, another is another investigation, prothrombin time. If it is raised, they more than two times of INR value. Again, another is a APDT, again which is raised in a platelet count. If platelet count is also decreased. And
how much time do you require for getting the results of this?
It will take within 1 hour.
Okay, within 1 hour, your lab gives all this report. APTT and PTINR, they give you within 1 hour.
Madam, it will take at least 2 to 3 hours, but if it is clinically for DIC,
and
then
so if I tell you that, you know, 35 years back, maybe Bharti and we share the almost the same area, era, we can say, we used to do a test, bedside test called as clot retraction time and clot lysis time. Okay. So this is, this is the one which is very, very helpful, you know, within 45 minutes, 20 minutes, 40 minutes, you get clot retraction time as well as clot lysis time, which is, you know, like how you get the APTT. You know, that is the time duration you can compare with APTT. So clot lysis time is actually when you are actually getting it, that you get the idea that yes, your patient is going into DIC. It's not forming the clot. In fact, it is getting lysed. That is how you get the idea. And you get that within 15 to 20 minutes, the initial BT-CT, 7 minutes you get it. And clot retraction, usually it should be 20 minutes. But if it goes beyond that, then you get an idea that the clot is not getting formed. So your patient is going into DIC. So all these, you know, bedside, bedside test for coagulation profile, you can definitely, they'll be of help. Till you are getting your reports from the lab, it will be too late. So you can intervene or take action before that. So that is how it is. And what kind of blood component you want to use for which problems?
Madam, in a case of an DIC, the first we will give the fresh blood transfusion because contain all coagulating factors. Another is a FFP, fresh
frozen plasma. I think we're not giving whole blood to any patient anymore, right?
at least 4 fresh frozen plasma is given at a single time, because the one frozen plasma gives on 50 milligram percentage of fibrinogen level, and the normal range of the fibrinogen level is up to the 150 to 300 milligram percentage. So at least 4 FFP should be given at a single time, and the biological life of this FFP is 4 to 6 hours. So it can be repeated, 4 FFP again repeat after 6 hours with the clinical assessment. And again, vitamin K is also important. The dose of the vitamin K in a case of existent form of the DIC is a 30 milligram aqueous solution is given IV slowly, daily continuous for 3 days, because it covers the vitamin K dependent factors. And another
available, which preparation is available? 30 milligram.
In
you have 10 milligram Kaplan, right?
10 milligram. So it is in an existent form of DIC, 30 milligram is given stat.
Right.
In an aqueous solution, slowly or daily continuous for at least 3 days. In a case of a DIC patient, again the anticoagulating agent it can be given tranexamic acid, 1 gram given IV 12 hourly. Again, there is mechanism of tranexamic acid, that it forms the thrombus at the capillaries and the capillaries at the level.
Right.
And if the oozing is stopped, then there is no role of tranexamic acid. But in case of DIC, it can be repeated without it can be given repeatedly.
Yes, 1 gram 8 hourly. That is what the FIGO recommendation is.
This is the line of management for the DIC, disordinate intravascular coagulation. And at least again there is a 4 fresh blood, 4 FFP, and the 4 platelet count. The platelet count, that the indication of the platelet infusion, that if the critical level of platelet is less than 20,000 with a spontaneous bleeding, then the platelet infusion can be given. The 1 bag of the platelet raise the 10,000 of platelet count. But the disadvantage of this platelet infusion, that the lifespan, the transfuse lifespan of the platelet is only 24 hours. That's why again go for the monitoring the patient for the platelet count, and again investigate the patient, and the fresh frozen plasma can be repeated 6 hourly or 6 to 8 hourly.
Right. So you have to monitor the coagulation profile. So Dr. Sushma, which component is given or required for which problem in the coagulation factor? Can you throw some light on this?
Packed cell volume, it increases the oxygen carrying capacity. So it increases hematocrit by 3 to 5% per unit. Then frozen plasma contains fibrinogen and all other coagulation factors like 5, 8, also contains antithrombin 3, which prevents the intravascular clotting. Useful for volume as well as coagulant replacement. FFP should be ABO compatible, not RH compatible. Then platelet should be given in 10 to 15 minutes. Single unit can raise the platelet by 5,000 to 10,000 per ml.
Whether it is single donor or pool donor, how you?
More preferable is single donor, madam. And in cryoprecipitate is rich in fibrinogen and factor 8, 13, von Willebrand. It lacks antithrombin 3. 20 ml of cryoprecipitate increases 200 milligrams of fibrinogen. Per bag of cryoprecipitate will result in 5 milligram per deciliter rise in fibrinogen. It should be RH compatible.
Correct. So that is how we have at least gathered the information. All of us now very clear on this. I'm sure this chart has definitely helped you to know which component is required when you have deficient which factor. Okay, so Dr. Priya, we have this last case for you.
Yes.
This is 4th gravida paravan. She's got 3 abortions, that is 2 MTPs and 1 missed abortion. Okay, her last childbirth is 7 years back, normal delivery. This time it is uneventful antenatal record, normal USG for fetal growth, placenta, liquor, everything. This patient was admitted late night in active labor. This patient delivered a healthy baby at 4 a.m. in the morning. Placenta failed to deliver by 4:40, almost 40 minutes later, still in spite of the active management of 3rd stage of labor. So, after some time, the doctor, of course, tried to go for the, a controlled cord traction, or maybe tried to remove the placenta. Suddenly, the patient collapsed and she was in pool of blood, pulse BP not recorded. So what is your differential diagnosis and how will you come to the definitive diagnosis and how will you manage this patient?
Ma'am, for this patient, my differential diagnosis is a patient had uterine inversion with due to retained placenta, and
inversion due to
the patient had retained placenta as the placenta failed to deliver, and she had a neurogenic shock which led to her collapse, and that's why the BP and pulse were not recordable. And I will confirm the diagnosis by clinical examination of the patient. Yes, I'll do the pervaginal examination, and if I feel a large mass which is prolapsing into the cervix, and per abdominally also I will examine if the uterus is
So
not.
the findings are like this, that when you do per abdominal examination, you don't palpate the uterine fundus. Locally, you find that there is a large fleshy mass and it's blood everywhere. You can't even see anything. When you try to do the per vaginal examination, you feel just the mass and you can't feel the cervical rim. What is the diagnosis, Dr. Pallavi?
Ma'am, that is a second degree.
Okay.
Pallavi, please say.
Yeah, thank you, ma'am, for the question. So we can see with the history that patient is having sudden postpartum collapse, and there was history of difficulty in removing the placenta, and also she has 3-suction evacuation. So I think that in this case they try to forcibly expel the placenta, and along with that the uterine acute complete uterine inversion was that, and that's why since I think the morbidly adherent placenta could be the cause here, leading to the adherence of the placenta and further leading to the complete inversion of uterus on traction. So the diagnosis here is acute complete inversion of placenta, of uterus, sorry.
Acute complete inversion of the uterus. But if it is completely adherent, does it bleed? If the placenta is completely
No,
adherent.
ma'am. If it is completely adherent, of course, it won't bleed that much with the pool of blood it is saying. So it must be focally adherent, which leading.
It may be just there can be various possibilities.
Yeah.
But adherent placenta will be one of the possibilities, right? Sometimes it is only short cord. Sometimes it is you are trying to put it unnecessarily. So faulty management of third stage of labor. Okay. Then sometimes you have placental attachment of the fundal attachment of the placenta. So suddenly the fundus comes out. So atony, uterine atony itself is the cause of uterine.
Cause of the
just give little traction, it will come down. Okay. Even at cesarean section, you must have observed that sometimes it does happen.
Yes, acute inversion.
So uterine atony can be one of the reasons. So how do you manage this patient now? You tell me.
So, ma'am, since it is acute inversion of uterus, so in this case, what we have to do is first the patient we have to start the resuscitation, which is patient is having
first and foremost always say shout for help.
Help,
because you will not be able to do
one
the
thing.
things. Put in IV and manage the inversion.
We will call for help. Certainly, we'll first thing we'll call for help, and then what we'll do is first we resuscitate the patient, start the IV fluids, and see for blood and blood products. Till then, we will and also since we can see that there is a fleshy mass, we can for the specific management we will start to reposit the uterus. So what we do is we will place the palm of the hand on the fundus of the uterus with the part which is outside, and then fingers at the periphery, and then we'll start to reposit the uterus by applying upward pressure with the fingers. And the principle in inversion of uterus is during the reposition the part which comes out first should be last to go inside, and so the fundus would be last to invert back. So since in obstetric cases it is easily the inversion reposition of inversion is possible because os is open and it is flaccid uterus, and then we will keep our fist inside or palm inside the uterus, and then we'll start the uterotonics and we'll keep the palm till the uterus contracts well. And yes, after that we can
if it doesn't correct, if it doesn't get corrected with this,
if it doesn't get corrected and the loss of blood is continuous, then we will think for the other management. That is first we will see for hydrostatic pressure hydrostatic method, in which we try to occlude the vagina.
Even when she doesn't bleed, but if she's in shock because of inversion, you have to repose it.
Reposited.
Okay, yes.
Yes, ma'am.
So if that
Reposited.
doesn't help, then you have to go for hydrostatic correction. How is
Correction. Ma'am, in hydrostatic method of correction, we will occlude the vagina with the one hand, with the one we supporting, and then we'll start to force this line through the nozzle, like 5 liter of saline we will push with a force, and so that the water force hydrostatic pressure will distend the vagina and the parts will go inside. But if the hydrostatic method fails, then the other method, surgical methods, will go towards a surgical method, which is vaginal and abdominal. In vaginal method, there are two methods. First, there are two according to the incision to be given on the rim. So first is anteriorly we can incise, and the second one is posterior rim could be incised, and after incision it will open up, and then we can invert the uterus back.
Then
But
repose, not invert.
repose, sorry, repose the uterus back into the pelvic cavity.
And
If
abdominal?
In abdominal there are two methods. The first method we do is after opening the abdomen, we will look for the dimple, and then we'll took Alice and we will apply Alice on the dimple, and gentle traction will give to reposit the uterus.
Okay.
Yes, ma'am. And if this fails, then we can do is again we can do the incision of rim in abdominal procedure. We can anteriorly incise or
What
posteriorly
is that
incise.
simple method? You just put in your hand anteriorly, put your hand posteriorly, and you just flip the uterus like this. Okay, that is Halston.
Halston's method.
So Halton's and Huntington's. These are the two procedures mainly. And
Abdominal.
like you said for vaginal, there are also the abdominal. Cut the cervical
Spinalis method, anteriorly
or
we cut, and
posteriorly.
for Kushner's method we posteriorly cut. In abdominal also, if cutting of the rim is anteriorly, it is Robinson's, and posteriorly it is Halton's method. And Ali's application, it is Huntington's method.
Okay, so even if this doesn't happen very often, if it happens, the patient goes in shock. So all of us should know this, because you have to manage it then and then. Once it comes, inverts the uterus, you have to push it, repose it at the same time, so that, without anesthesia, you can do it, and the patient's shock automatically reverts. Okay, so all of us must know this. So now I think last case, Pratima, for you. We take it very fast, quickly, just few messages here. You have this grand multipara admitted to emergency ward at around, late night. She comes to you with obstructed labor. You find that she's got tachycardia, blood pressure is normal, but mother is exhausted, and there is a thick meconium stain like her. So with antibiotic cover, fluid resuscitation done, and she was taken for cesarean section. Cesarean section was otherwise uneventful. There was a small extension which was repaired properly. There was no bleeding inside the abdomen. Hemostasis was well achieved. This patient was shifted to ward, and within an hour or so, this patient, started getting excessively sweaty. Respiration was disturbed. Her blood pressure was 80 millimeter of mercury only. She was having confused look, drowsy, and vomiting tendency. When you examine this patient, there was no pallor, there is no bleeding, absolutely no bleeding outside, and even the abdomen was soft. There was no bleeding inside. So what is your diagnosis here, and how will you manage this patient?
Ma'am, since the patient shows symptoms of shock despite any visible bleeding and well contracted uterus, the differential diagnosis for this case will be massive pulmonary embolism, as she has complaints of as there is respiratory distress and
You say
hypertension.
1, 2, 3, 4. This is basically non-hemorrhagic shock, right?
Non-hemorrhagic shock.
Okay. So what is your differential diagnosis? You are saying one pulmonary embolism. What else?
Amniotic fluid embolism.
Okay. What else?
Sepsis, septic shock, because she was in obstructed labor and she had
But then
exhaustion.
over a 12 hours or so. Okay. What else? So you don't have any clue, why suddenly everything was normal. So you do her bedside investigation. That is the best. Okay. So you do her bedside investigation. You find hemoglobin 10.8 gram%. So not to worry for bleeding. You do her bedside sugar very high, around 550 or so. Urine sugar 3+, urine ketones 2+. Now you tell me what is your diagnosis.
It can be ketoacidosis.
It can be knee. This is
It
very
is ketoacidosis.
It is diabetic ketoacidosis. Okay. What will you do now? Your patient is bad already.
We'll immediately start with the immediate resuscitation. We'll
Hmm.
look for
So
the
what will
airway.
you do for her resuscitation?
First, we'll look for the airway. We'll call for help for the help of senior
Yeah, that
anesthetist.
somebody else will do for you, physician and anesthetist.
Then
Okay.
we'll check for her breathing. We'll start high flow oxygen for her. If possible, we'll try to intubate her. But if intubation
No,
is
no,
not,
no, no. She is breathing well, only little disturbed. But then what about her sugars? And what about her ketones? You have to manage that, no?
ma'am, we'll have to give her insulin.
How much?
Uh, dose
Okay. What about, why this happens, diabetic ketoacidosis? You can see here that, vomiting
ma'am,
tendency, confused look, all this, she is dehydrated. She's dehydrated. Okay.
and that baby weight was also 4 kg, so she was diabetic and she was not taking any treatment. Then we'll have to give her fluid management. We'll have to start her on insulin. We'll have to correct potassium also. We'll have to give potassium correction for her. And
that Dr. Bharati will talk to you, but because, whenever you have a case of diabetic ketoacidosis, usually you have to give her on fluid resuscitation, because this usually happens because of the dehydration. I have said that, initially also, because she was dehydrated, exhausted, so she was given fluid resuscitation that time also, but maybe that was not sufficient. But when you have such high sugars, you have to give insulin. I think we go to Dr. Bharati for this. Dr. Bharati, how will
Yes.
you manage this patient? How we usually manage this patient?
Yes, madam. So depending on the need-based fluid management should be there. Even always for these patients, fluid management according to the need we give. Look for the urine output. Look for the blood sugar is already high, so you will call for the help. The same patient with the same scenario, I have managed another way also, which was not having metabolic hypoglycemia, but she was having hyperkalemia. The case of PIH was under treatment. Before just pre-op, everything was normal.
Yeah. We'll come to it later, Dr. Bharti, but how will you manage this? How to manage this patient?
Here, general management for the resuscitation.
Here you have the definite diagnosis that yes, she is in diabetic ketoacidosis.
Yes, she is having ketoacidosis. So the fluid management according to the we give the according to the urine output and the insulin levels. So usually we give the insulin for insulin infusion. We usually correct with the 75% appropriate fluid deficit according to the fluid deficit.
So this, this is called as aggressive fluid resuscitation. 75% of the fluid deficit you give over 24 hours.
Over 24 hours, yes.
Okay. So 100 ml per kg per body weight that you have to give it at the earliest. The initial IV fluids is normal saline. Okay. Initial first 1 liter you have to give it over 1 liter per hour that you give for 2 hours. That means within 2 hours you give 2 liters fluid. Okay.
Yes.
That is how it is, because she is dehydrated and that is why she's landed up into this problem. So after 2 hours, then we have to bring down to this normal saline. This was hypertonic saline. The initially what physicians use is hypertonic saline. Okay. And then they come down to normal saline once you find that, they add this insulin to this infusion. And once the glucose levels come down to 250 milligram percent, then they switch over to 5% dextrose and DNS, that is 5% dextrose, 250 ml per hour, how we give otherwise later on for maintenance. So we have to continue these fluids for 24 to 48 hours until the anion gap and acidosis have been corrected and the fluid deficit has been replaced completely. So we have to replenish the fluid loss first. That is our priority, because of dehydration, all these things have happened, and giving insulin will lower the blood sugar level. So these things we have to do it simultaneously, hypovolemia as well as hyperglycemia.
But
That
for
we
these
have to-
patients, yes, for these patient, first always have the bedside test of first the with the glucometer sugar level, check for the sugar level. Also see for the ECG also. See for the ECG whether tall waves are there or the ST depression is there. So you have to rule out other pregnancy
things
associated
also. Correct.
coronary artery dissection because which is causing the myocardial infarction. So you have
that
to
is
rule
why-
out all these things also.
Yes, that is why see any bedside investigation. So naturally hemoglobin coagulation profile also and blood
clotting,
sugar and ECG. Bedside echo also, as you rightly pointed out, sometimes
These three investigations
amniotic
I
fluid
always do: BTCT, glucometer, and the ECG.
X-ray chest, ECG, echo, all these things, because you can't jump to the diagnosis unless you have the glucometer showing high blood sugar levels. Okay. And of course, such patients, if at all she is not responding to the initial treatment of physician in front of you, if the physician is managing and in spite of giving insulin, if it is not coming, down, then of course you have to transfer this patient to ICU. But what message I want to give you from this patient is, whether it could have been prevented, yes, 100%. If all of you screen these women at the very
Macrosomia is
first
there,
point
so
of,
you must have this in mind.
Please say something. Who wants to say? Pratima, what is the message for this patient? What is universal screening?
It should be done at the first antenatal visit whenever the patient comes to us. We should do the basic OGTT for her, and first and after, if it is more than 200, then we'll have to start her on
OGTT, how do you interpret, Pratima? What is the cutoff limit to say screen positive?
If it is more than 140, then we consider it positive. Then if it is more than 140 and less than 200, we'll start her on MNT. And if she is able to maintain sugar on that, then we'll continue that. But if it is more than 200, then we'll have to
over diabetic.
We'll have to
Over
label it
diabetic. You have to
over
put her on anti-hyperglycemia or hyperglycemic agents, that is insulin on priority. Correct. So the simple, you have to have the dictum, or you have to have this in mind, that universal screening for diabetes during pregnancy is recommended for every woman during every pregnancy. Okay, not that some women say लास्ट मला तर पहिल्या प्रेग्नन्सीला काही नव्हतं डायबिटीस वगैरे, मग माझी कशाला करायची, मला मध्ये पण नव्हतं. सो नो, every woman during every pregnancy, first pregnancy she may not have, but second pregnancy she can have. So every pregnancy, every woman during every pregnancy should be screened for GDM or diabetes during pregnancy. And very simple way of OGTT, 75 gram single step OGTT. The patient need not be fasting. सगळ्यांना परत एकदा तेच सांगते, आज तू जेवून आलीस, आज नाही होत, ही गोष्ट नाही. Irrespective of her status for meal by mouth, irrespective of her timing for the last meal, you must investigate her for OGTT, give her 75 gram of glucose, dissolve in 200 ml of water, ask her to drink it over 5 to 10 minutes, note down the timing, ask your lab assistant to take her blood after 2 hours exactly, and then you interpret. If it is less than 120, 140, then it is negative. But in that also 120 to 139, it is called a GGI, that is gestational glucose intolerance. Correct? So that is how we have to keep it in such a simple investigation, because we did not do for her. She landed up into these problems, right? And that is how we should be very, very alert, and we should follow all the protocols for us. Anything anybody wants to add? I think, see, all of us know everything. What I would like to conclude is, every obstetric unit and every person from that obstetric team should be trained and skilled to manage the maternal collapse. You can't say the physician will come and manage. No, because this is happening in your hospital in front of you. You have to be well versed. What you have to do is, you train your staff who will communicate, who will do put in the IV lines, who will do the catheterization, who will take the lab, that That is called as delegation of your work. So your staff should be well trained, and you should communicate with them. You should, assess them from time to time whether they really remember all these things, and you should conduct the mock drills from time to time, so that whenever you have the emergency, they don't fumble and you don't land up into problem. So the team should be able to manage effectively then and there only. For this, we should have an efficient multidisciplinary team, and not only SDO. If you just have SDO, it is of no help, but your team should be well trained. So referral in unsettled condition may worsen the situation. You may lose the patient on the way. So you cannot refer the patient. Even law doesn't allow you to refer the patient in unsettled condition. So with this, I thank all the panelists, from young to senior ones. I thank you, all of you, for having a wonderful discussion, and of course, adding lots and lots to our information. So I thank all the panelists, and of course, my dear friend Monica, for having arranged this program, very well coordinated. I thank Dr. Kiran Kurtakoti, the President of Amogs, Dr. Bipin Pandit, Secretary, and of course all our chief guests, Dr. Kiran Kurtakoti, and I hope Dr. Bharati Abhankar is here. Monica, could we have her?
No, ma'am, she's in an emergency. That's what she told me.
Okay.
I
No
tried to
problem.
call her up around 7 o'clock, but she isn't picking up her phone, ma'am.
Okay. So we thank Dr. Ameya, Dr. Bharti, and we thank both the society president, secretary, Dr. Dipali Shukla, our dear friend, and of course, Dr. Shalaka. I could not see actually. Dr.
Ma'am,
Shalaka.
she's in an obstetric emergency.
Okay. So
Yes.
Dr. Shalaka, and of course, our own society president, Dr. Charuta Ranade, Dr. Sushma Tarak, our secretary, and all my dear panelists, all the society members from both the societies. Thank you so much, everybody. I thank both the speakers who are, excellent orators, and I'm sure this must have added value to your knowledge. Thank you so much, everybody. Over to you,
Thank you,
Monica.
madam. Thank you for
Thank
giving us an
you,
opportunity.
Sahiti, for
I
an
think
excellent
Dr.
technical support.
Bharti has to say something. I think Dr. Bharti.
Yeah, thank you, madam. Thank you for giving us an opportunity. Thanks a lot.
It's my pleasure, my dear. Always very happy to have all of you.
Thank you.
Thank you, Dr. Bhupendra,
Madam.
Pallavi,
Thank you,
Priya,
ma'am.
Thank you, ma'am.
and of course, Pratima, Neetu, all the panelists. I'm very happy that, I could cover most of the important things, and you all could add, lots of inputs to this discussion. Thank you so much.
Thank you, Sahiti and Shield Pharma, for giving us an academic platform. And thank you, Sneha Madam, for giving me this opportunity to coordinate this webinar. Thank you all the esteemed faculty members for being so supportive and being so supportive to answer all the questions. I'm sure all the delegates have had a good take-home messages from this webinar. Good night, everybody. Thank you so much.
Thank you.
Good night.